क्या पीता है, नेक्स्ट ही तो पीता है सारा पाकिस्तान, पाकिस्तानी टेस्ट।
Good afternoon, everybody. We are going to be starting in 5 minutes. We would like you guys to settle down. Please call your friends, your students. We're going to be starting on time. That has been a trademark of the society. Our programs start on time. Our programs end on time. I would like you to request all your students, all your friends who are around, please send them a message to be here. Otherwise, they're going to lose the moment. Thank you.
Open.
We're going to go. Yeah, don't worry. हमने इतना पता है. Bismillahir Rahmanir Rahim. Welcome to Best of ASCO 2026. Adnan Jabbar is once again here to welcome you all. Before we do anything, let's begin with the blessings of Almighty. What you will hear are the last two verses from Surah Baqarah. Bismillah.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم لله ما في السماوات وما في الأرض وإن تبدوا ما في أنفسكم أو تخفوه يحاسبكم به الله فيغفر لمن يشاء ويعذب من يشاء والله على كل شيء قدير آمن الرسول بما أنزل إليه من ربه والمؤمنون كل آمن بالله وملائكته وكتبه ورسله لا نفرق بين أحد من رسله وقالوا سمعنا وأطعنا غفرانك ربنا وإليك المصير لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ما اكتسبت ربنا لا تؤاخذنا إن نسينا أو أخطأنا ربنا ولا تحمل علينا إسرا كما حملته على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين.
Subhanallah. May Allah bless us all and give us the strength to be true to this holy book and our profession. Next, as always, we'll be dedicating next will be the dedication to this beautiful country that we all belong to, a country that has given us the identity, a country whom we all love as much, I would say we all do not love as much as we should. May I please request you all to rise for the national anthem of Pakistan. Note, this year it is a karaoke. Let Lahore hear your voice all the way. परजमे सितारों हिला करे तरक्कियों कमाल. Come on, guys. तर्जुमाने माजी शाने हम जाने इस्तकबाल साये खुदाए ज़ुलजलाल. Pakistan Zindabad. I think Karachi did it better in PSL final. Come on, guys. I was hoping everybody is going to join in. All right, so let's begin. Where were we? So as always, this is our 8th Best of ASCO, and I would like to introduce a gentleman who went to New York for his postgraduate training in 1992. That was the time when I graduated myself. He went to New York, St. Luke's Roosevelt, and that's where he stayed until he graduated and finally came back to Pakistan in 1998. At that time, Dr. Najib joined Shaukat Khanum first, and then he moved back to Karachi. I think there's a history where whoever goes to Shaukat Khanum either comes to Karachi or they move back. I guess we have 2 more examples. Dr. Nihal came to Karachi, and I think now there's someone else who's going to tell himself who's moving to Karachi. But then he joined LNH and was with the EKU for a long time until he moved to Shaukat Khanum once again. And he has been affiliated with Shaukat Khanum and SIUT since to date. You all know whom I'm talking about, Dr. Najib Nehmatullah. He has been a mentor and a role model. I would certainly consider him to be my mentor and a role model. He's a name who is synonymous to patience, a name who is meticulous, because when I send the agenda to him, he's the only one who sends out mistakes in it. So if you can, whoever knows me, the OCD, and if he can find it, he is a meticulous gentleman. A very down-to-earth person. You call him, he's always there to help. Please join me to welcome the current president of the Society of Medical Oncology with a big hand of applause.
Thank you very much, Dr. Adnan. वैसे मैं इंग्लिश में तो लफ्ज़ नहीं है, उर्दू में कह सकता हूँ, ज़रा नवाजी थी. Okay. Bismillahirrahmanirrahim. Nahmaduhu wa nusalli ala rasulil kareem. Auzu billahi minash shaitanir rajeem. Bismillahirrahmanirrahim. Thank you very much for Adnan for giving me this honor. Okay, I welcome you all for the 8th annual meeting of Society of Medical Oncology, Pakistan. And we are doing this Best of ASCO in continuation. We started in 2019, and then we did 2 years of online Best of ASCO, and then since then we are doing it in Karachi or Lahore continuously. So welcome to the 8th Best of ASCO 2026 under the umbrella of SMOP. In this meeting, our theme is this Wazir Khan Mosque. This mosque was built in 17th century in the era of Shah Jahan, Mughal Emperor. And it's in the list of heritage buildings. Okay, last year was really a tough year for us, SMOP as well as the whole oncology community. We lose our dear friend and the executive committee member and the founder of SMOP, Dr. Neelam Siddiqui. And then suddenly we lost Dr. Arif Jamshed, who is a clinical oncologist at Shaukat Khanum Hospital. And our old dear friend, Dr. Colonel Salim Siddiqui. And I know him, I think, almost 25 years back since 25 years back, when we were doing FCPS examination. At that time, there was nobody here to take the exam except a few of us. We also, in our family, we have Dr. Adnan, who lose his sister, and Dr. Tariq Siddiqui lose his brother recently. So I think let us observe a moment of silence in their honor and recite Surah Fatiha for the departed soul. Ameen. Okay, this year we have included, after a transparent election, we added two new executive committee members, Dr. Jamshed Ali from Peshawar and Dr. Qasim Buttar from Islamabad. So during the past year, the one thing which highlights is now we are a member of IFNOS. IFNOS is the International Federation of Head and Neck Oncology Society, and yesterday they endorsed Society of Medical Oncology give us a membership, and they gave us a full session in their World Congress. So Dr. Yasmin is leading that team, and she worked very hard for this thing. Okay, SMOP always look for the arenas of oncology education and research. So we are a member of Asian Oncology Society, Global Cancer Control Society, UICC, as I said, Head and Neck Society, IFNOS, and ACCORD, which is an Australia and Asia Pacific Clinical Oncology Research Development Workshop. Okay, this is RECON is the recognized at the world stage, and this is a resident and early career oncology network, and this is basically an initiative established in 2024 under the umbrella of SMOP. And the RECON mission is to bridge gap in structured mentorship, research exposure, and professional skills for oncology trainees and early career in Pakistan and other low and middle income countries. And in ASCO, they recognized the RECON work and gave International Development and Education Award to RECON member Sadhna Sir. Okay, SMOP also support the young oncologists, and they went to Asian Oncology Society meeting, Japan Cancer Society meeting, ASCO Breakthrough in Singapore, and ACCORD Research Development Workshop, and presented their research, and they have an opportunity to meet experts in their fields. IFNOS fellowship is also given to one of the Pakistani student, and this will be done at Memorial Sloan Kettering. There were like only three fellowships awarded this year. Okay, in order to build the infrastructure of oncology, we published clinical guidelines for lymphoma in Pakistan and low middle income countries, and now we are working on multiple myeloma guidelines. We have developed a members portal so that the things can be more streamlined. The multiple education sessions held throughout the year, including immuno-oncology, which is very well attended. We arranged a urology master class, which was delivered by Professor Syed Hussain, a very renowned name in uro-oncology. And yesterday and day before yesterday, we have a 2-day meeting on ENCORE. ENCORE is oncology research and education. And in this 2-day meeting, there were didactic lectures on how to do research and how to publish. This time, the new thing is CME credit by CPSP. So you can earn CME credit for every session. And what you have to do is, you have a code on your card. So what you do is, you scan the QR code which will be shown on the screen after every lecture, means after finishing the lecture and before the panel discussion. And then answer the feedback and submit your feedback, and that will give you a credit, CME credit. And last, I would like to thank the whole executive committee for arranging and doing hard work for this meeting. And behind the scene, we can't do much without these two persons, Waqar, जो कि हमारा वकार है, and Mohammad Anas. These two are working day in and day out throughout the, I think, past 1 month or so to make this possible. In the end, I would like to end my talk with this prayer. Rabbi yassir wa la tu'assir wa tammim bil khair. O Allah, make this task easy and do not make it difficult. O Allah, make it end well. Jazakumullahu khair, and thank you very much for your attention. Okay, our next session is Dr. Salim Siddiqui Memorial Plenary Session, from discovery to delivery, drug development, quality and access in low middle income countries. And I would like to request Dr. Qasim Putter, who worked with Dr. Salim Siddiqui for a long period of time, to pay tribute to him.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank Dr. Zeba Aziz. It was her idea basically, and I am thankful to the whole SMOP Executive Council who approved it immediately without even thinking. So I was given this task because I have a long association with Sir Salim Siddiqui since 2001, and obviously this task was had to be co-managed by Dr. Azmina, who unfortunately could not travel back from USA, but she has sent her kind words for me to read that out, and then I'll give my reflection on Sir Salim Siddiqui Sahab as well, obviously. And secondly, I would also like to thank all the SMOP members who confided in us, me and Jamshed, to vote for us so that we could become the members of SMOP. So these are Dr. Azmina's words. I'm reading it out for you, that today we remember not only an outstanding oncologist, but also an extraordinary human being. I had the privilege of traveling with him on several occasions, and those journeys allowed me to see a side of him that extended far beyond his remarkable professional accomplishments. We often admire our senior colleagues for their knowledge, their leadership, and dedication to the patients. But what stayed with me most was the quiet kindness which resided throughout his life in Sir Salim Siddiqui. What struck me deeply was the beautiful partnership he shared with his wife. She accompanied him on many of those trips, and together they exemplified mutual respect, warmth, and unwavering companionship. It was evident behind the accomplished physician was a loving husband who valued his family as much as he valued his profession. Their bond was a reminder that a life well lived is measured not only by the lives we touch through our work, but also by the love and care we share with those closest to us. As an oncologist, he devoted himself to easing sufferings and offering hope during some of the most difficult times in patients' lives, and his legacy will live on not only in the many physicians he mentored and the patients he cared for, but also in the example he set as a person of integrity, humility, and genuine kindness. May we honor his memory by striving to emulate the compassion he showed his patients, the generosity he extended to his colleagues, and the love he shared with his family. May he rest in eternal peace, and may his family find comfort in the remarkable life he lived and the enduring impact their lives behind. So these were Dr. Azmina Taj Wali Muhammad's words. Now, as far as I go with Sir Salim Siddiqui, I go a long way back when I joined medical oncology as second fellowship in 2001. And I had a long relationship, first as a teacher, as a mentor, as a counsel, and then like a fatherly figure. And I have also traveled with him a lot in different international meetings. He did his internal medicine boards in 1970 and then trained for 2 years in medical oncology. And in 72 and 3, it was decided that American board will conduct the first American board examination in the field of medical oncology, and it was recognized as the separate specialty in 1973. So he was among the first successful batch which passed that examination, and I have absolutely no hesitation to say that he was truly a pioneer in the field. And he also remained president for a period of American Cancer Society in the main chapter. Then he moved to King Faisal Hospital, Riyadh, Saudi Arabia, as the chief medical oncologist, and he served there with dignity and pride and honor for 4 years. He was a great physician, an excellent teacher with great clinical skills and clinical acumen, and he was always applying what he learned from the conferences and the literature. And those were the days when net was not that common. We only had journals which came through post to us, and he was always the first. I will give you a couple of examples that he used interleukin-2 therapy in a metastatic RCC patient when it was experimental, and it was available in USA. The patient arranged, he advised, and he was probably the first patient who was treated with interleukin-2. The second case I remember was a young lady with triple-negative breast cancer, and she had consumed almost all the options with metastatic disease, and then all of a sudden he prescribed Casodex, 50 milligram twice a day. The guy who was the patient's husband was a manager at the Watson, so he was surprised. He met another oncologist, I won't name him, but he said that probably Dr. Saab has grown old and now he's suffering dementia. So that was one of the few examples that he was using the latest developments on his patients. Then he joined Pakistan Army in 1984 and served there till 2000. And Sir Naeem Naki is also here, so I have heard from a lot of senior guys in physicians in Army. Even my cousin is also one of the brigadiers who trained under him. And even late General Ayub, they spoke very high of Colonel Salim Siddiqui, that he brought new ideas in oncology, and a captain was teaching generals at his time, so they remember him very, very fondly. Then he joined Shifa International till his last day of his life in 2000. And he brought the latest therapies, he tried to use them, and he always taught us and the students and peers. He was a wonderful human being. He was a great practicing Muslim in the true sense of the word. He was a thorough gentleman, very soft-spoken, very humble, very down-to-earth. He was very compassionate and empathic for his patients. He was always there for the patients. I have never seen a person whose mobile phone is open for 24/7 for the patient's call, and he never ever once frowned on a patient's call. This is rarely seen. Then obviously he was very updated, and in 2019, he voluntarily appeared in the recertification exam, and he passed it, and at the age of 79, and this speaks his quest for knowledge and better therapeutic options for his patients. And by the way, in 2017, I was a witness of that letter and that email. Aga Khan University offered him the role of the chair in medical oncology, which he respectfully declined because he didn't want to move to Karachi. He was a philanthropist, he was a humanitarian, and he has financially helped so many families that probably some of my pharma colleagues and friends know that there are still a lot of families who are being supported by Salim Siddiqui Sahab. He was a great family man, and Dr. Azmina alluded to. He was a loving father, a loving husband, and he always valued family dinner when he was in Pakistan. He never, ever for once had dinner outside other than his family, while her wife was alive, that is. And the next quality was calmness. That was basically calmness personified. In the difficult situations, I have never seen him in any hurry whatsoever, in rounds or in patients' consults, and I always envied that how come a person can be so calm and collected under so much pressure and distress of talking to the family and the patients. And since 2001, when I took my patients, my files to his home clinic, he used to do his clinic at home. It was just across Pakistan Institute of Medical Sciences where I was working. And I was always given priority, I was always welcomed, and a lot of our pharma colleagues will agree with me that they were always offered coffees and drinks, and there was never ever a penny charged to me, and I was always given priority regarding patient cases. And now one side of him being a patient himself, he had lots and lots of diseases. He had chronic asthma, he had hypertension, he had chronic atrial fibrillation, he had aortic stenosis, which eventually became very, very disabling in 2025, and he had to undergo aortic valve replacement in 2025, which he tolerated very nicely, and that is totally purely due to his willpower. He also had, some of us might not know, that he also had a gastric neuroendocrine tumor grade 1. That was picked up on endoscopy, and the very next week it was taken out by endomucosal resection. And surprisingly, maybe Kamran will agree with me that he was up and about and there straight from the procedure to the clinic for the patients. That was the level of commitment I have seen, which came out of a surprise. And he bore those with so much sabr jameel that even we were surprised. And he accepted Allah's will, and even we were surprised that how can a person bear so much with so much sabr. And although he might have been heartbroken and broken from inside, but he remained ever so calm for the loved ones and us. And he even gave us sympathies whenever we tried to console him. Even on his last day, during the consult, while talking to the patient, he suddenly stopped talking, and his arm fell down, and he stopped communicating with the patient. And immediately Dr. Yazmir was called, and then eventually he was taken to the emergency, and he underwent thrombolytic therapy over there. And even after thrombolytic therapy, when I saw him, he was smiling. He acknowledged me with the wave of the hand to tell that everything was fine. And that was the last time I saw him. And then he was taken to CMH, and obviously then he went to the ventilator after the surgery and unfortunately passed away. For him in 55 years, patients always came first. And discomfort and everything came behind if at all, and he was there. And he was a father figure to me, a lot of other people like me. He was the person whose judgment I sought before even my own judgment on my medical problems, on my oncology problems, and be it any problem in my life. So he'll be always missed, and he is sorely missed. Inna lillahi wa inna ilaihi raji'un. May his soul rest in peace, and may Allah bless him with the highest ranks in Jannah. Thank you very much.
Thank you very much, Dr. Bhutta, for these words for Dr. Siddiqui. May Almighty Allah give him highest place in Jannah. Ameen. Okay. Let's start the session. Our first speaker is Professor Wasif Muhammad Saif. He is an internationally recognized expert in gastrointestinal oncology and experimental therapeutics with particular expertise in pancreatic and colorectal cancer. Dr. Saif has served as principal investigator on more than 150 clinical trials. He is very well published and he served as on the editorial board of numerous peer-reviewed journals. Dr. Saif currently serves as a leader of Phase 1 multidisciplinary team and director of the Eisenberg Center for Transitional Therapeutics at the Barbana and Karmanos Cancer Institute in Detroit, Michigan. He also is a professor of oncology at Wayne State University School of Medicine. Dr. Saif is a proud graduate of King Edward Medical University, Lahore, Pakistan. He is going to talk about targeting the untargetables, Resolute 302, and the new era of KRAS directed therapy in pancreatic cancer. So please welcome Dr. Saif.
Assalamu alaikum. Okay, so now today is one of the most exciting days in our life. You can see I'm wearing a purple bow tie. There's a purpose. I was not wearing the same bow tie this morning because I have to change it. Why? Because purple stands for fight against pancreatic cancer. And for the first time in the history of pancreatic cancer, we can say that we can target the enemy. So what is that enemy? We know that pancreatic cancer is the deadliest tumor. Among all the tumors that we know, we are faced as human beings. 40 years ago, we learned about an enemy. We realized that about 90 to 95% of the patients with pancreatic cancer are linked to KRAS mutation. We learned about the biology, but we were not able to target the KRAS. But very proud to say that 2 days ago, a drug was approved by FDA, which targets the KRAS and has changed the treatment strategy for pancreatic cancer. So KRAS, as I told you earlier, is one of the oncogenes which are responsible for about 30% of the solid tumors. The most common tumor is pancreatic cancer, followed by lung cancer. So what is KRAS mutation and how it works? I think it's very important before we go into the data to understand that how the KRAS works. So KRAS is basically, think about like a light switch on and off. So KRAS is an oncogene that gets into the on and off position. When it's in on position, it really goes to the signal transduction and leads to the downstream to help the cell division. On the other hand, when it gets in the off position, stops sending the signal for cell division. But when somebody has a KRAS mutation, it's almost like your foot is stuck on the pedal, your accelerator. And what happens is that then the KRAS becomes stuck into the on position that continues to send messages and the cell cycle continues to go on and the tumor continues to grow and grow. And that is really what is KRAS mutation means. When we look at pancreatic cancer, we see that there are multiple types of KRAS mutation, but the most common one are G12D followed by V and R. I was talking to somebody this morning and they say, how do you remember these? And I say, you know, you are too young, but in our time there was something called VHS and then there was something called DVR. So basically D is about 60%, 40% patient, V is about 30%, R is about another 15 to 20% patients, and then of course we have Q61H and 12C. When we look at the real world data, we do realize compared to the wild type, as you can see in the graph, the wild type, which is the blue line, the rest of the lines which have KRAS mutation, it seems like they have a worse outcome compared to the wild type, which means the normal KRAS and no mutation. So since we know about the KRAS for the last 40 years, there has been multiple efforts to really develop a strategical approach to attack the KRAS. There has been some specific mutational basis inhibitors such as the KRAS G12C inhibitor, KRAS G12D inhibitor, and similarly we also have some pan-KRAS inhibitors which are going to attack all these subtypes of the mutation, and then we have pan-RAS inhibitors which are going to affect all the RAS pathway including the KRAS and RAS and HRAS. Moreover, since we learned about the biology and how this whole mechanism of on and off, we also start developing further deeper into this pathway to have a more durability of the response to try to build inhibitors which are going to work on KRAS on versus KRAS off. We have the history telling us that we developed KRAS G12C inhibitors. We have two generations of them. The first generation was Torasib followed by Adagrasib. If you go back, I told you earlier that unfortunately KRAS G12C is only present in less than 2% of the pancreatic cancer patients. So in USA, we see about 67,000 patients a year, which means that a very small proportion of the patient will have KRAS G12C, and of course the benefit from these drugs is going to be limited. As we further go into the drug development, we realize compared to the first generation, going to the second generation, we definitely see the response rate seems to be improving. But when you look at the PFS, you see that the PFS for Torasib was 4 months compared to 5.4. So it tells that yes, we are able to target KRAS, but the resistance is happening because these patients ultimately develop resistance and start progressing. So the great news is about Dexamethasone. The new name is called RAS-ONC. We were just discussing earlier. The new name is RAS-ON. As you know, this is a RAS-ON inhibitor. So the name is RASONQ, R-A-S-O-N-Q-U-E. So Dexamethasone or RASONQ was tested in a randomized phase 3 study compared to chemotherapy in patients with previously treated metastatic pancreatic cancer. The study name is Resolute 302. This was a late-breaking abstract at ASCO, and simultaneously the paper was published in the New England Journal of Medicine in June 2026. So first of all, let's try to understand how this drug works. So Dexamethasone is basically an oral RAS-ON inhibitor. Dexamethasone is going to combine with cyclophilin A. Cyclophilin A is basically a very abundant protein in the cells. It is an intracellular protein that helps to fold and transport different proteins in the cell. So DARA is going to attach to cyclophilin A and will convert into a binary complex. That binary complex will then further attach to RAS-ON, and that will lead to a tri-complex, and that tri-complex will then further work on the RAS pathway and finally will inhibit the RAF pathway that leads to the decreased cell division and finally leads to the tumor shrinkage. In the phase 1 and phase 2 clinical trial, Dexamethasone showed clinical activity with manageable safety profile in these patients, mostly consist of cutaneous side effects and GI side effects. So this is a study design. The Resolute 302 was a randomized phase 3 study. Patient with metastatic pancreatic cancer with any RAS genotype, ECOG performance status has to be 0, 1, and they have to have at least failed 1 line of prior chemotherapy. That could be a Gemzar-based therapy such as Gem-Abraxane, or could be a 5-FU-based therapy such as FOLFIRINOX. Patients were randomized to receive Dexamethasone at 300 milligram daily versus investigator's choice of standard of care, and the primary endpoints were looked at PFS, overall survival in G12 mutant pancreatic cancer patients. So the primary endpoint was met. Overall survival was amazing. As you can see from these graphs, they are immediately separated and remain separated even at the end of 12 months, with 53.3% patients alive who were on the experimental agent compared to a standard of care where only 18.7% patients was alive. When you look at the small table over there, you realize that the median overall survival for patient on Dexamethasone was about 13.2 months compared to 6.6 months on standard chemotherapy. When you look at the hazard ratio, it was 0.40, meaning that if you get the Dexamethasone compared to standard care of therapy, you have 60% decreased risk of dying from pancreatic cancer. And this is a magnitude of benefit we have not seen in the history of mankind for pancreatic cancer. When they look at the overall population, which means that looking for not only the KRAS G12, D, V, R, C, Q61H, but also with no RAS mutation, the benefit was found all across the patient population. And you can see again at 1 year, survival was about 52.3% for patient on the experimental drug versus standard of care, which was 17.3. When you look at the median overall survival, it was 13.2, very similar to the GRAS 12-based patient compared to 6.7 with a hazard ratio again of 0.40, showing your risk of dying from pancreatic cancer is reduced by 60%. When we look at the subgroup analysis, as you can see from their age, either less than 65 or equal or above 65, gender, male, female, ECOG performance status 0, 1. If you look at the RAS mutation status, either DVR or no mutation found. If you look at metastatic disease stage 4 at the time of diagnosis, prior 5-FU-based therapy, prior Gemzar-based therapy, either patient has pancreatectomy prior to getting enrolled to the clinical trial, patient with liver metastasis at the time of baseline diagnosis, peritoneal metastasis at the time of diagnosis, and the CA19-9 whether above and below 40. It showed that the pooled analysis that all these subgroups seems to benefit from daraxonrasib compared to standard of care chemotherapy. When you look at the response rate in patient with KRAS G12 population, the response rate was 33.2% compared to 11.6% with standard of care chemotherapy. When you look at the overall population that includes patients with no KRAS mutation, it was again 31.6% compared to 11.2%. I think it's very important to understand that it does tell you that yes, not only that daraxonrasib is a great drug, but also reminds you that the chemotherapy options we have available do work in selected patients because response rate 11.2 is definitely reassured us that the previous studies done in these patients do show that those chemo regimens are effective to some extent. Next, going to the toxicity of the drug. So the most common side effect of the drug is rash. The rash is very similar to acneiform rash that you are used to see with EGFR tyrosine kinase inhibitor or EGFR monoclonal antibodies such as cetuximab or Vectibix. It's an acneiform rash, occurs by week 2 to 3, become very ugly looking by week 4 to 5. You treat them with doxycycline, PO, you try to also give them clindamycin gel. You also use triamcinolone, which is a steroid cream for itch, and ultimately the rash comes to some level of plateauing, but definitely the rash is the most common side effect. Followed by that, the second most common side effect is mucositis. People do develop mouth sores, and what we tell them, from day one, I tell them to go to see a dentist, make sure that you are cleaned, your teeth are cleaned, there's nothing going in the mouth as a predisposing factor, and then I tell them to use a Biotene mouthwash or a baking soda-based mouthwash. Followed by that one, the next common side effect is diarrhea. So patients do develop diarrhea, which can be controlled with Imodium. Some patients develop nausea. Vomiting is very uncommon. We see fatigue, but also keep in mind that we also see hypomagnesemia. And learning from the stories of EGFR inhibitors, I believe that probably they go together. Some patients develop anemia, but overall neutropenia or thrombocytopenia was very minimal because this is not our systemic chemotherapy that we use in a conventional setting. And some patients have peripheral neuropathy, which we believe probably was pre-existing from the prior chemotherapy, either Abraxane or oxaliplatin. So again, rash is a very important side effect that you need to be educated and you need to create some handouts for the patient. And the way we decided that we treated about 137 patients just in the last 2 months with this drug, and we basically start the patient on doxycycline from the day one they start the drug. When we look at the patient reported outcomes, because quality of life is extremely crucial in pancreatic cancer, if you go back to the story of gemcitabine, which was approved by FDA in 1997 based on a study done by Burris. So what study, if you remember, the Gemzar was when approved, the ODAC FDA basically said that I do not know how good this drug worked to the cancer, but I do know it does good to the patients. Because it was approved based on the clinical benefit response, which included the pain intensity, requirement of pain medication, dry weight. So this drug also seems to continue to improve the quality of life and maintain the quality of life for about 9.2 months compared to 3.8 in patients who were on the standard chemotherapy. So definitely it also tells you that not only that patient seems to derive benefit and have a disease control and live longer on this drug, but also they seem to have much better control of the symptoms caused by the cancer. So the takeaway message from the study is that daraxonrasib met all the primary and key secondary points with statistically significant and clinically meaningful improvements in overall survival, progression-free survival, and overall response rate in patients who were previously treated with pancreatic cancer. Median overall survival was 13.2 months compared to 6.7 months with a hazard ratio of 0.40. The results support that this is the new standard of care for patients with previously treated pancreatic cancer. So when this study was presented, immediately the company opened an expanded access program, which means that any patient who has not been exposed to this drug and were not on the clinical trial can have this drug available as a part of the clinical trial. As I mentioned earlier, only in 8 weeks, we treated 137 patients all over the world, majority from Canada, of course, but USA followed by Canada. And I think at that time we learned more about this drug and the safety. And as you know, 2 days ago, FDA approved this drug to be given for patients treatment with metastatic pancreatic cancer who have received at least one prior therapy or not candidates for multi-target systemic therapy. So I think the FDA gave a very blanket approval for pancreatic cancer, which if you are seeing a patient who refused to receive FOLFIRINOX or Gem/Abraxane, it almost allows you that you can offer this patient this oral therapy. So as you can see that just overnight, we have a shift in the sequencing of treatment for pancreatic cancer. So the first line therapy could be Gem/Abraxane, could be FOLFIRINOX or NALIRIFOX, or in some patients Gem/Cis. As you know, we use Gem/Cis in patients who are BRCA1, BRCA2 positive. As you know, about 3 to 5% of the patients are BRCA1, BRCA2, and based on the study done by Elizabeth Eileen O'Reilly at Memorial Sloan Kettering, we used DNA adducting agents, so we use Gem/Cis, and if the patient has stable disease for at least 16 weeks, then they can continue to receive PARP inhibitors such as olaparib. But now you can see that we used to switch to the other regimen in the second line therapy, but now we have a drug called daraxonrasib, which has changed the entire intervention for pancreatic cancer. So now you can see there's a race. There are multiple RAS on, RAS off, specific RAS degraders, activators, multiple RAS inhibitors are going on in clinical development at this time. But the key element is that there are multiple studies now going on looking at pancreatic cancer. So there is a new G12D RAS inhibitor which is comparing against chemotherapy in a study. We have multiple first-line therapy studies going on which are looking at Gem/Abraxane plus minus the KRAS inhibitor. We have also studies looking at FOLFIRINOX as a backbone, and you can see that based on different ways of mode of action of these agents, there are multiple studies going on. And I think the rationale is very simple. We now know that we can target KRAS, but we want to go deeper and we want to create durability of these benefits. Also, Resolute 304 study is looking at adjuvant daraxonrasib in patients who will receive chemotherapy followed by surgical resection followed by chemotherapy, and they will either go on continuation of daraxonrasib or they will continue on observation. Keep in mind that in USA, it's very hard to do a randomized study where patient will be on observation. So what are the clinical opportunities in KRAS landscape at this time? I told you earlier that we want to go deeper and we want to improve the durability. So we're working at degraders and inhibitors, definitely combination of KRAS as a platform with other biologics, including immunotherapy. We also want to look at the new combination, not only A plus B and B plus C, but also using the AI tool to really generate synthetic lethality for these tumor cell lines. We also want to look at the wild type RAS targeting because we realize that this agent is also effective for patients with no KRAS mutation. And finally, we are going to look at the innovation, how we can have a maintenance therapy for patients so we can prevent them from the toxicities of systemic chemotherapy. So as you know that every drug ultimately has an expiry date, so there is definitely a lot of concern about the KRAS inhibition. There are different pathways. It could be the KRAS reactivation, upstream bypass, downstream bypass. So definitely there's a lot of work going on. I cannot say more than that, and I'm very blessed that I work with the top-notch basic scientists at KCI who are working on inhibition and KRAS inhibitors. So thank you very much.
Thank you, Dr. Saif, for this enlightening lecture. I still remember a picture on JAMA Journal of American Medical Association. There is a painting on pancreatic cancer. There is an old man sitting weak and emaciated in a park where there is falling leaves from the trees. The guy is depressed. So that is the picture of pancreatic cancer. And now we have hope in that. So I hope it's going to be curable. Okay, our next speaker is Dr. Tariq Arshad. Dr. Tariq Arshad Dr. Tariq Arshad is a medical oncologist and senior biopharmaceutical executive with more than 20 years of experience in oncology drug development, translational medicine, clinical research, and medical affairs. He currently served as the Executive Vice President and Chief Medical Officer of Bexion Pharmaceuticals, where he lead the clinical development of novel therapeutics in oncology, including metastatic colorectal cancer and neuro-oncology. Over the course of his career, Dr. Arshad has led senior leadership positions of successively increasing responsibility at leading pharmaceutical and biotechnology companies. Dr. Arshad has led the development of multiple first-in-class and best-in-class oncology therapeutics and has authored and co-authored numerous scientific publications and is very well published. He graduated from Allama Iqbal Medical College, Lahore, and today he is going to talk about cancer drug development, the long and winding road. So, Dr. Tariq Arshad, please.
Assalamu alaikum and good afternoon, everyone. It's a pleasure to be here. Thank you to the organizing committee for the invitation to speak. We will be changing gears slightly. My presentation, unlike Dr. Wasif's, is not based on a whole array of clinical data, but it is built on the backbone of clinical trials. What I've attempted to do is to summarize the past 25 years of experience I've had in clinical trial development and cancer therapeutic development in the form of 10 lessons. And the title of the talk is The Long and Winding Road. The irony is that I have to describe the long and winding road in less than 15 minutes. Every cancer medicine has two birthdays. One is the day it is imagined, when it is a twinkle in the eye of the scientist that conceives the target. And the second is the day that it is prescribed and saves its first patient. The purpose of my talk is to illuminate the distance between these two birthdays. It is indeed a very long distance, and many programs do fail. And what I would like to do today is to give you, the audience, a window into the level of effort, intensity, resources, and time that goes into this journey that delivers us a successful drug, such as the one that Dr. Saif just talked about, daraxonrasib. But there are many such examples. What you see here is a slide that describes, essentially visually depicts, the approval process for new medicines. This is based on a study that was done by BioQLS and Informa, which is a survey of clinical trials done between 2011 and 2020 in oncology. And the key statistic I'd like to highlight for you from this study is that only 5% of programs oncology programs that are in phase 1 actually succeed, meaning actually go into approval. Another way to look at this is that if you have 100 programs in oncology in phase 1 clinical trials, 95 of them will fail. So when you see a medicine like daraxonrasib or others that are approved, please appreciate the amount of effort it took and the amount of failures it took for that medicine to reach approval. The first lesson is that biology is a map, but it is not the destination. This graphic you see at the center representing tumor biology is influenced by multiple factors, including heterogeneity, biomarkers, combinations of drugs that can address the tumor biology, a changing and ever-evolving standard of care, as well as tumor resistance, which KRAS is a very good example of, where we are seeing resistance emerging for the KRAS G12C inhibitors. The first lesson is that cancer is not a static target. It is heterogeneous and ever-evolving. Lesson number 2, undruggable is often a temporary verdict. One of my favorite sayings is that no is simply the first 2 letters in not now. And in drug development, we often live by that paradigm. Taking the example of KRAS G12C that you see here, this was discovered linked to human cancer back in the 80s. And it's taken a long, long time for us to get to the point where we now have an approved KRAS targeting therapy for pancreatic cancer, but also previously KRAS G12C targeting therapies for other forms of cancer, including colorectal cancer. Persistence has basically led us to the point where we have these approved therapies for targets that otherwise were considered undruggable for a very long time. So that's the second lesson. Undruggable is often a temporary verdict. Lesson number 3, translational science is a relay race. So if you remember the Olympics, there's a race that is called the relay race where runners pass the baton from one to the other. The sprint is not the right way of looking at drug development. We actually have discovery passing the baton to translational medicine, passing the baton to early clinical development, passing the baton to late clinical development. That is how the industry works. And as you can see here, these relay races can last not just years, but decades. The BCR-ABL target took approximately 40 years to get to the point of approval. HER2 and VEGF, which are very well-known targets, and we have therapies that are not only approved, but now genericized, targeting these targets, they took 14 to 15 years to be approved. And then PD-1, PD-L1 immune checkpoint inhibitors, which we almost take for granted at this point and we use very commonly, those took more than 2 decades to develop. So again, it is just a lesson in persistence and the ability to move drug development from one stage to the next seamlessly without letting failure bring the program to an end. Lesson number 4, the right drug in the wrong patient is the wrong drug. And we have seen this time and time again where therapies that are defined by biomarkers, if the biomarker is incorrect, if the underlying biology is not conducive to the therapy itself does not work. The graphic here shows several examples of tumor agnostic therapies that were approved across a variety of tumors, but had an underlying common biomarker, such as NTRK fusions for larotrectinib, or PD-1, PD-L1 expression for pembrolizumab. The lesson is that biomarkers can change the denominator. Lesson number 5, dose of the drug is a biological decision. It is not a race to the maximum tolerated dose. In traditional drug development paradigms, the MTD, or the maximum tolerated dose, is what we look to achieve. But with time, and especially with additional guidance from the FDA, we have now reconfigured the paradigm to optimal biological dose, OBD. And there, instead of looking at the peak exposure or the Cmax of the drug, or trying to define the ceiling of the drug through toxicity, instead we look at the right combination of dose with activity. And especially as we enter a phase of drug development where we are developing antibody drug conjugates, immune stimulatory antibody conjugates, as well as other immune structures or architectures, OBD, optimal biological dose, will be the future. And we will talk about maximum tolerated dose or toxicity less and less. Lesson number 6. Early efficacy is a signal, but it is not a verdict. We have seen time and time again that drugs in phase 2 that have encouraging overall response rate have complete responses and partial responses on solid tumor using RECIST 1.1 criteria, oftentimes do not see that benefit translated in phase 2, or if the benefit is in phase 2, it oftentimes is not translated in phase 3. Early efficacy is a signal, not a verdict. Phase 3, when you do see the efficacy replicated or recaptured in phase 3, and that results in approval, that is exceedingly rare, and that links to that 5% statistic that I showed you at the beginning. I think this gives us perspective regarding how much appreciative we should be when a drug does show that kind of effect in phase 3, especially with, when it's powered to have a statistically significant effect. I'm going to speed through the rest of the slides because if I may speak a little bit of Urdu, मेरी बारी उन्होंने यहाँ clock लगा दिया. So I have to stay on time. Phase 2 is where optimism meets attrition. Phase 2 is in the industry is called the Valley of Death. According to a study, almost 30% of all phase 2 trials do not, 30% succeed, 60% do not go into phase 3. So again, this gives you an idea of the level of attrition that's involved. And this may also be germane as we talk about the cost of drug development and the cost of medicines moving forward. Lesson number 7, randomization is where narrative, scientific narrative meets reality. Many times, small biotech companies, startup companies conduct single-arm studies where they demonstrate an observed outcome that is favorable for the patient in a given indication or a given biomarker-defined population. However, when that is applied to a control arm, the narrative does sometimes fall apart. That is where randomization plays a key role, and randomized clinical data carries its weight in gold. Single-arm studies can oftentimes be exciting, encouraging, but also misleading. I'll skip this slide in the interest of time. Lesson number 8, toxicity is information. As we look at immune checkpoint inhibitors, T-cell engagers, and antibody drug conjugates that are being developed in the hundreds, if not thousands, across the industry, we see that the toxicity that these kinds of therapies elicit can really help guide the development of the drug. For example, right now I'm working on an immune-stimulating antibody conjugate being developed for Claudin 18.2 expressing metastatic gastric cancer. And I'm running the clinical trial across multiple sites across the world. What we're seeing with that, the payload is TLR7, TLR8. So we see a lot of systemic inflammation coming from that. And in fact, we do see a high amount of cytokine release syndrome. This is information that we're using to guide our dose, our dosing frequency, as well as the pre-medication protocol for the immune-stimulating antibody conjugate. This is one example of how toxicity information is being used to guide efficacy development for these immune platforms. Lesson number 9. A program, a clinical program, is a sequence of decisions. It is not a single experiment. In a clinical program, these are called go, no-go criteria. Each stage has a predetermined set of criteria according to which the program has to achieve certain levels of safety, tolerability, and efficacy in order to move to the next stage of development. Each stage of development requires significant investment and commitment from the sponsor or from the biotech organization. This is a path that tests many drug development professionals and really requires a lot of persistence to keep going in the face of suboptimal early clinical stage data or toxicity data that may suggest the drug may not be able to succeed. We saw, as Dr. Saif described for daraxonrasib, the side effect profile including rashes, which had to be overcome by Revolution Medicine in order to take the drug forward. And that obviously requires a lot of discussion and alignment at the executive level in these companies. Lesson number 10, time can be compressed, but evidence cannot. We have seen that the FDA has increasingly leaned in favor of providing accelerated approval for a number of therapies, especially therapies like daraxonrasib that can double the survival benefit in otherwise diseases that so far have not seen that kind of benefit. And yet the FDA also is very strict in requiring confirmatory evidence. And there have been instances where approval has been withdrawn for some drugs where confirmatory phase 3 evidence was not provided. It is very important that sponsors working with their sites structure their clinical trials not only to achieve accelerated approval, but also to provide confirmation. And this links to the point that I made earlier regarding ORR, PFS, and OS. OS is still the gold standard, and therefore confirmatory evidence will require a minimum of PFS evidence, but also OS. A medicine succeeds only when the right patient can receive it. And this is a chain of value-creating milestones that you can see here on this slide. Each chain represents years and years and millions, if not billions of dollars worth of investment. And it requires I promise I am going to finish on time. And it requires a huge amount of investment from these companies. So as we think about the role of clinicians here in Pakistan, oncologists, my respected colleagues in the audience, as well as standard of evidence. Thank you.
Thank you very much, Dr. Arshad. A very enlightening talk. Okay, our next speaker, everybody knows her. So I think it's a very difficult task to introduce her because everybody knows her. So Dr. Zeba Aziz is the professor of medical oncology at Hamid Latif Hospital, Lahore. Her journey includes MBBS from Fatma Jinnah Medical College, Lahore. Then she went to US and gets a diploma in internal medicine and hematology oncology. She came back to Pakistan where nobody knows about medical oncology. She established a department of medical oncology first in Sheikh Zayed Hospital and then in Jinnah Hospital, Lahore. And then she started fellowship program in College of Physicians and Surgeons, Pakistan. She was first dean of the department in the faculty of medical oncology at CPSP. And she not only is doing clinical work, but she is doing research also, and at the same time she is representing Pakistan in multiple international forums. And she is also a supervisor of many of oncologists in Pakistan and abroad. Dr. Zeba is the founding member of Society of Medical Oncology Pakistan, and she is the first president of medical oncology. Okay, मैं आपका time नहीं ले रहा हूँ. So she is going to talk about challenges in access to new therapeutic agents. So please welcome Dr. Zeba Aziz.
Assalamu alaikum. We'll change gears now from all the wonderful talks from the USA and come back to our land of opportunity. So what I'll discuss is challenges in access to the new therapeutic agents which are coming to Pakistan or have come to Pakistan, and what are we doing with it? Sorry. Whenever we talk about cancer, it's a deeply personal disease that touches nearly all of us. But whether a person survives cancer should nowhere depend on where they are born and what they earn. This is by Tedros Ghebreyesus, who's the WHO Director General. In a recent report from WHO in July 26, 2026, cancer became the second leading cause of death, and it is claiming about 26,000 lives annually. But with all this, there's persistent and widening inequities in access to prevention, diagnosis, treatment, supportive care, and also survival. Only 1 in 3 countries include cancer care in their universal health coverage. Breast cancer, if you look at the disparities in breast cancer, 87% are alive in high-income countries versus only 42% in our part of the world. Cancer is a financially difficult challenge, and a household can face multidimensional poverty and sinking into a debt which is never replaced. Nearly all caregivers on a personal level report strain, social isolation, and unpaid services, and these are the husbands, wives, children, everybody, and siblings too. Cancer rates in different global regions varies markedly. Asia has a large population, which has 50% of all cancers and 56% of all deaths. On the other hand, Europe has 9% of the world population and 20% of the global cancer cases, and only 20% of deaths because of effective treatment. Africa and certain part of Asia have a lower incidence of cancer but higher mortality. 4 in 10 cancers are preventable and we don't look at them. HPV, hepatitis B and C, alcohol, tobacco use, obesity, and insufficient physical activity, which marks all of us sitting in this room and outside. The cancer profile is evolving, and it is increasing the obesity rates, unhealthy diets, and air pollution, which has recently become one of the more common causes of cancer, accounting for 8% of all cancers. And the reason I know about it is because in UICC, I'm working with air pollution. So what did Elizabeth Wittenpass say of the IARC? While we are seeing reduction in some cancer rates in countries that have implemented prevention policies, progress has been too slow. The cancer profile is evolving, increasingly driven by preventable factors, and these are all factors we can work on and advise our patients and even otherwise, but we are not doing it. Obesity, physical inactivity, outside food, unhealthy diets, and air pollution. A lot of patients come with their children and say, oh, he's obese or this is happening, but the money comes from the parents because it's an easy way out to give them money so that they can eat out. We've made some major gains, but yet gaps persist. Tobacco use has declined by 27%, with reductions in lung cancer and deaths in some areas, but we are still seeing a lot of lung cancers here. Infection-related cancers are decreasing due to an expanded vaccination coverage. We don't have good water sanitation for a marginalized population. There is no education about hygiene and infection prevention and control. Only 82% of countries have a national cancer control, and the low middle income countries have it on paper, not actively being pursued. In high income countries, early detection and screening are being performed for breast and cervical cancers, and that is why we see the falling rate of mortalities in breast and cervical cancers. For essential cancer therapeutics, 20 priority cancer therapeutics are available in 9 to 54% of low middle income countries, but 68 to 94% in the high income countries. We are wasting a lot of our money on targeted therapies, which in some cases and some diseases do not make that much of an impact as they should, because we are doing, I don't know what we are doing, I'm just confused. So cancer is not just a medical diagnosis. This is a survivor of childhood cancer who said it's not a medical diagnosis. It affects profoundly, indefinitely, every aspect of a person's life and their family. Moving towards a people-centered cancer control agenda includes better capabilities, integrate cancer control into universal health coverage, and invest in human capital to prevent and control cancer. What is happening is we do have the Sehat card, but we are not investing in human capital to prevent and control cancer. We are giving medicines right, left, and center on the Sehat card without thinking what we are doing. Better protection, better value. There is no value for the drugs which we are prescribing because we just are doing it because we want to do it, and I'm at the cost of all of you sitting because we are greedy as doctors. And I think this is where we need to look at ourselves and evaluate ourselves critically. Are we doing the right thing or not? In low middle income countries, most new cancer cases and cancer mortalities occur in our part of the world. Mortality to incidence ratio is 0.45 to 0.75, and there are several reasons for it. Advanced disease, lack of access to cancer centers, which is only in the major cities, lack of access to basic cancer medicines, but we have access to the immune checkpoint inhibitors. As a result, we do have suboptimal therapy. Significant economic and social impact, lack of prevention and early diagnosis, and lack of resources at the government levels due to competing diseases. On the government side, we have a very fragmented health system, complex regulatory mechanisms, procurement issues, supply chain fragility, absence of pharmaceutical and diagnostic capabilities which are very expensive, weak early detection capabilities and we don't spend there, and lack of universal health coverage and costly health care. This is the economic data of Pakistan for 2025-26, and the poor are approximately 40% in our part of the world. The middle class is 40% and the rich are 20%. The share of, this is a paper we published in 2018, and I'm giving you the data for now, but basically what it shows is what the landscape in Pakistan is. It was published in the Journal of Global Oncology. The share of the national income is 25% for the poorest and 36% for the richest. And this is the amount of average monthly dollars. If a person has cancer in the poor or the middle or the rich, this is how much is the 10% of the income they have, and this is how much in dollars and how will they spend it. So let me just look at the comparison of the GDP, health, and out-of-pocket expenditures which all of us have to make when a diagnosis of cancer is made. Pakistan only spends 2.9% of the health GDP on health, and out-of-pocket expenditure is 60%. Bangladesh also has a very high one, 71.89, compared to Iran and to India, and Europe and USA have less out-of-pocket expenditure. So when we look at the socioeconomic status, This is the share of national income, and this is what we did. And when you look at the cost of early breast cancer treatment, you look at the top, and this is where the low-income patients with early breast cancer come. And even if the government gives subsidy, just look at that, 30 or 40% are not able to complete and abandon therapy with just adriamycin and cyclophosphamide. If you add Taxol to it, this is 20 to 25%, and with trastuzumab, in the poor patients, less than 10% complete their treatment. In the middle income country, the figure is much better, while in the high income bracket, which is our part of the world, in the middle income bracket, more patients complete, and in the high income bracket, nearly about 80 to 90% complete their treatment. And the same is true for lymphoma. And if you look at lymphoma, nearly everybody completes their treatment compared to the poor who just abandon treatment, and less than 10% will get the R-CHOP on time. What about the targeted therapies given for marginalized patients? For trastuzumab, optimal therapy is completed in only 10% patients, abandoned in 60%, and 6 months of therapy is only given to 20 to 30%, which I think is enough, but we still abandon it after. Rituximab, only 10%, in marginalized patients, 60% will complete 2 to 3 cycles of rituximab, and they abandon therapy, and 10% complete them. Imatinib, on the other hand, which was a government-sponsored program, 85% of patients get their 5-year therapy. So this is the socioeconomic realities, and can we provide health coverage from this? Novel therapies are becoming now the standard of care in developed countries, and we know that health expenditures do not always correlate with outcomes. If you look at the cost effectiveness of new drugs and you calculate it, for UK it's 30,000 the quali, for USA 50,000 to 150, and for WHO proposed for LMIC's use is times 3 the GDP, which I already showed you. Now, I was in the last meeting for the EML list in last year, 2025, and checkpoint inhibitors were approved. Now, if you look at the checkpoint inhibitors which were approved after a lot of fight from low middle income countries, there are very few, and the indications are also very few. Pembrolizumab, atezo, and sempelupinab, first-line monotherapy, with only greater than 50%. In CRC, as first-line for MSI and deficient MMR, and Pembro as first-line in cervical for greater than 1%. Pembro is used as a square box because it says that nearly all the checkpoint inhibitors are interrelated. And once they said that these are essential medicines, they asked each country to list it for themselves, looking at the financial risk, procurement, opportunity costs, limited availability of diagnostic, financial sustainability of the health budget, and especially if we want universal health coverage. So by 2050, new cases are projected to be around 35 million. What choices we make today and actions we take today will shape the cancer burden borne by the future generations. We need to make a patient-centered approach, making strategic and sustained investments, and maintaining an unwaverable commitments to equity and reduce the cancer burden by early diagnosis and screening. Thank you.
Thank you very much, Dr. Zeba, for this important talk, bringing into light the issues we have in using new molecules and other issues. Okay, our next speaker is Julia Segafredo. She's a pharmacist, epidemiologist, and global health professional whose work focuses on accelerating equitable access to essential and innovative medicines in low and middle income countries. She led the access activities for the non-communicable diseases and maternal health portfolio at the Medicines Patent Pool. Prior to joining Medicines Patent Pool, she worked in the pharmaceutical drug development, market access and health system strengthening programs across several LMICs, particularly in sub-Saharan Africa. She holds a master's degree in pharmaceutical chemistry and technologies, a PhD in epidemiology and public health, and is a registered pharmacist. She is going to give a talk on equitable access to innovative cancer medicines. Can we accelerate progress? So, please welcome Julia Segafredo.
I would like to start thanking the Society of Medical Oncology Pakistan for the kind invite and for the very interesting topic of the presentation that was assigned to me. My name is Julia Segafredo. I'm a pharmacist and have a PhD in public health, and I'm currently working with the Medicines Patent Pool, which is a public health organization based in Geneva, and that is focused on accelerating the access to innovative medicines in lower and middle income countries through voluntary licensing. The topic of my presentation today is really to share some consideration of how we can accelerate and access to innovative medicines and how we can try to make it more equitable. I think that cancer is an extremely interesting area where to share this consideration, as cancer innovation is accelerating, is extremely fast, but the key question here is whether access is following innovation at the same pace. The good thing of having a very fast-paced innovation is that survival of many cancer patients is transforming. However, many countries, including Pakistan, are finding themselves facing the challenges of how making sure that this innovation can be bridged to patients. If we look at FDA approval back in 2024, we could see that in the full year there were 44 new drug approval, and 9 of these had an oncology indication, making oncology the most represented disease area among the newer registration. And if we have a look at the categories of medicines that were approved, we could clearly conclude that precision oncology continues to dominate, which clearly brings extremely positive, effective advantages for patients. But from an access perspective, it also means that medicine are increasingly requiring molecular diagnostic before use to identify the eligible patient. And the second conclusion that we can draw from an access perspective is that antibody drug conjugates, or ADCs, are becoming a major oncology platform, which again this is representing a clear opportunity for patients, but from an access perspective, it requires us, access actor, thinking more broadly about how to manufacture these complex biologics in a more efficient way, developing appropriate regulatory and fast enough regulatory pathway, and broadly how to improve affordability. So when we think about access in the global health area, we have different framework. I usually refer to the framework that was developed by Frost and Reich back in 2008. And as much as I don't want to go into the details of the framework, what I like to underline is that access is a multidimensional issue. And here we identify 3 big dimensions, which are affordability, availability, and adoption, that together really match building an architecture of access. As such, access solution or an access strategies really need to respond to a multi-dimensional set of challenge and requires an access architecture to respond to all the challenges. But what I think is extremely interesting is that most of the structured access framework often do not tackle the dimension of time to access, which is instead of one of the topics that is part of these presentations. So how can we accelerate access? And according to my understanding and according to the evidence that are available in Pakistan, time to access is one of the issues that also affects Pakistan. This study published back in 2024 was assessing what is the number of medicines that are included in the essential medicine list, that are also in the WHO essential medicine list, that are also part of the national essential medicine list, and that are also part of the registered essential medicine list. And if there's a total overlap between the WHO essential medicine list and the national essential medicine list, we could see that only 73% of the medicines in the national essential medicine list were also part of the registered essential medicine list, meaning that there is a time lag between the two processes. The study was very interesting, and it drew many conclusions about why this can be observed, but I picked two that I think are extremely interesting from our perspective. One is the need of a stronger alignment between the regulatory and the registration path, and the second is a lack of cost-effectiveness data that is often one of the main reasons for rejection of anti-cancer drugs. And while I think it is important to really include the dimension of time to access in all our reasoning and all our strategic architecture development, I want to go back on an assessment that we performed last year, which really focused on the cost-effectiveness, some cost-effectiveness consideration on immunocheckpoint inhibitors. And back 2 years ago, the WHO Cancer Medicine Working Group reflected on the fact that immunocheckpoint inhibitors were medicines that are extremely important to have in a essential medicine list. However, because of affordability, many countries are lagging behind in terms of access. So we decided to design a cost-effectiveness assessment to understand what could be the price threshold for immunocheckpoint inhibitors to be considered cost-effective into lower middle-income countries. And the idea was really to generate evidence to guide global health policy and potentially improving access. We focused on the lung cancer indication for obvious reasons, the high incidence and impact from an epidemiological perspective, but also the great result and the importance of immunocheckpoint inhibitors in this specific indication. And we clearly focus on the advanced non-small cell lung cancer with a high expression of PD-L1. Just a couple of information on the methodology. We use a partition survival model. We modeled the cost-effectiveness for all the three immunocheckpoint inhibitors that were indicated, that had this indication. So atezolizumab, cemiplimab, and pembrolizumab, and we model it versus the standard of care in lower middle-income countries that we have identified as platinum-based chemotherapy. The model was designed for South Africa and India. Clearly, we would have liked to have more countries included, but we wanted to start from this country. And as there are no commonly accepted willingness to pay threshold, WTP threshold, we use the GDP based threshold to inform the incremental cost effectiveness ratio. So we use the 1 time the GDP threshold, the 2 times GDP threshold, and the 3 times GDP threshold. Country-specific data were collected through interviews with key technical stakeholder and country level, and we used efficacy and safety data from pivotal phase 3 clinical trials. So the results highlighted that the maximum acquisition cost for immunocheckpoint inhibitors to be cost-effective at 1, 2, and 3 times the GDP per capita in India and South Africa range between 14 USD dollars and 648 USD dollars per cycle per patient. However, I think it's extremely useful to try to put this information in context. So let's focus on South Africa. If we compare the current acquisition cost of pembrolizumab and immunocheckpoint inhibitors in South Africa, we realize that to meet the 3 times GDP threshold in South Africa, a discount of up to 86% would have been needed to become cost effective. However, we also wondered whether there was an analog that we could understand, that could help us in understanding what are the price dynamic of medicines, especially when biosimilar version of monoclonal antibody come to the market. So we managed to retrieve information about the price dynamic of trastuzumab, which is another monoclonal antibody. And we realized that between 2014 and 2026, the price of trastuzumab declined of exactly 86%. But what is also important to underline is that trastuzumab was actually launched in the country back in 2001. So we didn't manage to retrieve the price at launch, but we are absolutely confident about the fact that if we compared the price of trastuzumab at launch and the current price of of trastuzumab in the public health sector, the price reduction would be way more and more important than 86%. Going back to our model, we also try to understand whether other strategies such as dose optimization strategy or low dose and vial sharing could have been impactful and feasible in improving cost effectiveness, and all these strategies proved to be effective and achieve partial price reduction. So this study had several limitations, and most of them were related to the fact that we were performing this assessment from a public health perspective, which may not reflect current practice of the use of immunocheckpoint inhibitors in lower middle income countries, and clearly the lack of the challenges in collecting in-country data. However, if we focus on the conclusion, we can all agree on the fact that to make immunocheckpoint inhibitor cost-effective in all countries, including lower middle income countries, significant discounts are needed. And however, similar price reduction have been achieved for other monoclonal antibodies, such as trastuzumab, in India and South Africa. And these price reduction were also driven by the availability and uptake of quality assured biosimilar. So biosimilar can be an opportunity to improve affordability. And as I was mentioning earlier, complex issue requires complex solution. A comprehensive approach combining accelerated biosimilar availability, also leveraging voluntary licensing and technology transfer with dose and treatment duration optimization strategies could help achieve target price levels and improve accessibility. So I think that here, one of the key questions that we want to ask is whether we want to wait until biosimilar reach the market following the natural course of action, or if there's any tool such as voluntary licensing that we could leverage to accelerate the availability of biosimilars. And this acceleration would mean that this price rationalization could be achieved earlier and faster compared to the normal natural cycle of medicines. And I believe that you might have one question about the feasibility of voluntary licensing in the cancer space. Voluntary licensing, which is an agreement, a partnership developed between an originator, a pharmaceutical company, and generic partners to allow generic partners or biosimilar partners to develop, manufacture, and distribute generic version of the innovative medicines in the countries, proved to be a very effective method in the HIV space, but it's a rather new access tool in the NCD space and indeed in the cancer space. So the question we had in the past years is whether this tool was also applicable to cancer. And the answer is the first example of the first license that we signed with Novartis back in 2022 for nilotinib. So a license that was included in 44 countries was signed between the Medicines Patent Pool and Novartis. And if we look what happened in these 4 years, after we signed the license in 2022, we selected the 4 generic manufacturers to partner with in 2023. As of March this year, 2026, 3 out of 4 of these generic manufacturers received a stringent regulatory approval for their generic version of the medicines. And as of June in 2026, as of June in 2026, the product were registered in 7 countries, with 9 countries with more than 1 filing, which is an extremely important information to improve competition and drive price down. And the product was supplied in 4 countries, covering a total of more than 800 patients. The price reduction varies according to the country, but the biggest price reduction that was observed is over than 90%, which means that patients are accessing a quality assured and more affordable version of nilotinib, which we all know needs to be used on a daily basis, on a chronic basis. So as we are reaching the end of the presentation, I just wanted to conclude sharing a couple of ideas of what could be some opportunities to accelerate equitable access in Pakistan. And clearly, identify high-impact medicine is the first step. Closing the registration and the formulary gaps can be an opportunity. Pooled or smarter procurement, where possible, have been proved to be effective tools to improve and strengthen supply chain. As mentioned, considering the type of medicines that innovation is bringing, planning diagnostic and medicines together is of vital importance. And we can collectively think about how to use global tools, such as voluntary licensing, by accelerating the availability of biosimilar and using technology transfer strategically to make sure that patients can have access to innovation. And with this, I thank you, and I invite you to reach out to me in case there's any question.
Okay, very nice lecture. Okay, may I request all 3 speakers, Dr. Wasif Saif, Dr. Tariq Arshad, and Dr. Zeba Aziz, to please come on the podium for panel discussion. Okay, we are going to show you a QR code. Please scan this QR code with your camera. And then with this QR code, there will be a opening of a page in which you have to write your code which is written on your card. And that will lead to a form which you have to fill, the feedback form. And once you send that feedback form, then you will get an attendance. So it's hardly a 1-minute procedure. And we are going to show this QR code after every session before panel discussion. Dr. Tariq Arshad. Okay, the floor is open for questions. If you have any question, please ask. First, introduce yourself and then ask question.
Okay. I'm Dr. Amjad Zafar. I'm a medical oncologist. And my question to Professor Zeba Aziz would be, I mean, in HCC we have seen that some is perhaps better than no immunotherapy. And with the cost constraints and there's so many focused talks on cutting the cost and using only the medicines which are appropriate when they're appropriate within a certain budget. So do you think it's a wise idea probably to go with 3 months of immunotherapy and perhaps then tailor the things accordingly to the response of the patient?
It depends on how you want to. You have to have a clinical trial. There's no data right now. But we do know that after 6 or 8 cycles, even 12 cycles, you do see a plateau in patients who discontinue the treatment. But there is no systematic trial to show it. What it is showing is that after 24 cycles or 2 years of therapy, you can stop it and the survival is similar. And that is in lung cancer. So if you want to do this, you have to have a clinical trial. Without that, we can't conjecture anything.
On the same note, I would like to ask Professor Wasif. There's some patients of HCC in which we see after like 6 months of therapy with atezolizumab, let me say, or a year of therapy, I mean, they have been in sort of complete response. They show complete response. And now, there are more than a few patients of mine who have shown complete response. So they sort of come to my clinics and they ask me that, I mean, I've been having complete response since the last 2 CT scans, that's almost like 6 months, and they have not completed the 2 years of therapy. We know that 2 years is an arbitrary point. So should we be offering them a respite? Should we discuss the pros and cons and maybe offer them surveillance instead of going for the 2 years? Because cost is a major issue here.
So I think that your question is very important. I've been listening to all of you guys, and I can give you an example. I was sitting there and looking at the cost for Rezonk. You know the cost for Rezonk for 1 month? $40,000. So it just tells you that how many of these patients can even receive that therapy over there. We have the insurance companies, and there's still a co-payment. Even your co-payment is $2,000. Not every US citizen even can pay for it. So now going back to the immunotherapy, if somebody has a complete response, I think you can definitely have an open dialogue and offer those patients a close monitoring. At the same time, what I'm learning also over the last 3 years, that even for the monitoring, we don't have all the tools. If I will be monitoring that patient, I will be inculcating circulating DNA, alpha-fetoprotein, and imaging as a part of my observing that patient, because I want to make sure I catch the disease before it's going to be radiologically evident. So I think what I am thinking in my mind that you guys need to reach out to the companies and see if they have biosimilar studies. They need patients for biosimilar studies. And I think one of the approaches that how to get over the issue with the cost is to reach out to these companies and see if they're willing to do biosimilar studies in Pakistan.
Okay, thank you.
Assalamu alaikum. My name is Jamshed. I am medical oncologist at Shaukat Khanam. So I have 2 questions, one from Dr. Tariq, and thank you very much for the nice talk. So what is an ideal endpoint for randomized controlled trial? As you mentioned in your lesson number 6, I think it was slide 18, there are objective response rate, PFS and OS. And I think PFS is not a king now. And if we insist on overall survival, it will definitely delay the approvals. So I would be interested in your thought, which one is the best one? And for Dr. Wasif, very, very excellent talk. So you, as we saw that there was a small group of the patient who had no mutation, and without mutation, we got the approval. Although it was we don't have the subgroup analysis, and there is very small group, do you think at this time we can consider this result 302 trial for those patients who have no mutation? Thank you.
Thank you very much for your question. So I believe that ORR, overall response rate, is emerging as a really compelling efficacy endpoint and is now being used by the FDA as well as other regulatory authorities in order to trigger approvals earlier and earlier than before. A very good example of this is the approval of Braftovi or encorafenib, which is the BRAF V600E targeting therapy from Pfizer, which was recently approved. I think it was middle of this year. approved in BRAF V600E mutant metastatic colorectal cancer. And the initial approval was before that. So I think at ASCO GI in January, announcement was made that accelerated approval has been given to Braftovi in BRAF mutant metastatic colorectal cancer based upon ORR. And that was the basis for it being allowed to be prescribed for that in first line metastatic colorectal cancer. But then subsequently, the PFS data was required by FDA for approval. So FDA is not going to back off. They are going to require at a minimum PFS for these solid tumors. But I think in the advanced setting, they will not require OS. In settings where the trial is going to require years and years, they are not going to require OS. They will suffice with PFS. But accelerated approval is now being given for these high unmet need indications based on ORR.
So I will just add up further to it. So I think, as you remember, I mentioned the example of gemcitabine. In the history of solid oncology, there are only 2 approvals which were done by FDA based on quality of life. One is the gemcitabine versus 5-FU. Second is the myoxantrone and prednisone in prostate cancer. But we are talking about 30, 40 years ago when we do not have too many options. Similarly, when it comes to the endpoint by FDA, since I work very closely with them, just like Arshad, the point is that it's also the disease and the setting. So what disease you are trying to talk about? Are you talking about colorectal cancer versus HCC versus pancreatic cancer? So definitely, they are not going to be approving something for pancreatic cancer on PFS. That's the reason for directional SAVE, it was overall survival. And I think when you look at the magnitude, and we always discourage comparing a study to a different study, but the median overall survival for stage 4 pancreatic cancer with chemotherapy has been maximally 10.2 months with FOLFIRINOX. Here we're talking about a second-line therapy giving you a 13.2 months survival. So definitely the bar is going up and up, but as he mentioned, there are orphan diseases where FDA is willing to allow a drug on accelerated pathway. That's they call it accelerated pathway, where sometimes the drugs are approved initially based on the response rate or PFS and then want more data. Now going back to Drexel so in this study, there were patients with no RAS mutation. And we found that those patients also seem to benefit. As I told you earlier, that we treated 137 patients in the last 8 weeks because people are desperate, and we included those patients. So there's going to be tons of data generated now on those patients that we'll be learning over the next year to 2 years. And as I mentioned earlier, the issue is that now we know how to target it. That's a good news. But we also know that there's going to be resistance to RAS inhibitors. So I think that is going to be the next step, that how can we really do something to deepen the benefit and extend the benefit duration. So this is going to be an interesting exercise for us. But the good part is that the enemy that we knew 40 years ago, we know how to attack the enemy, and I think that is the success story.
Okay, Dr. Butler.
Assalamu alaikum. I'm Dr. Kausar, and my question to the panelist is that we are talking about the targeted testings and targeted drugs and economy. But my question is very basic. The patient who have negative testings and we start them on chemotherapy in lung cancer, metastatic lung cancer, and they are doing well on the chemotherapy, the disease is controlled. So how long we can continue these therapies, or we should stop midway and we should wait for the disease progression again? Because I have quite a number of patients who are doing well. They are in partial remission for a long period of time. And my question is, I always ask it myself that if I stop the treatment, would it increase? I have no other options. So how long we can continue these therapies?
So I think, first of all, I think every cancer is different, every stage is different, every patient is different. So even we have 2 patients with the same cancer type and same stage, their biology is different, their comorbid conditions are different, and of course their tolerance is going to be different. So I think it's going to be, so I always tell this is the time for precision oncology, but I was just joking yesterday with my lecture yesterday, there is something called tailored oncology. Tailored oncology means that you tailor according to the clinical scenario of that particular patient. We also know that giving chemotherapy, for a longer duration is going to lead with cumulative toxicity. Let's take an example of FOLFIRINOX. So in the ACCORD study, we give FOLFIRINOX up to 6 months. We never go beyond progression, beyond 6 months, because we know, and most of the time we stop oxaliplatin by 4th month, because we do not want patient to have a crippling neuropathy and they have no quality of life, and then we'll continue with either 5-FU leucovorin or 5-FU leucovorin irinotecan. Similarly, we know and learn from the small cell lung cancer, even I don't treat it, I do remember it's still the same, that you treat them with a platinum plus taxane, and you don't go beyond 4 cycles and sometimes 6 cycles. But then we realize that now we add atezo to the chemotherapy. We give the chemotherapy for 4 months in most cases, but if somebody does not have a optimal response, we give them 2 more cycles, but then we stop it irrespective and then go with the atezo till progression. So I think the incorporation of the immunotherapy or biological therapy has really allowed us. If you remember, I gave you an example of BRCA1, BRCA2 pancreatic cancer. We give them GemCis, and if they have a partial response or stable disease for more than 16 weeks, which is 4 months, then we can stop the GemCis because cisplatinum is going to be nephrotoxic. These kidneys will be bad for the rest of their life. They have neuropathy, they may have autotoxicity, they have thrombocytopenia, and Gemzar is also not a very benign drug. It does cause thrombocytopenia and myelosuppression. So then you put them on olaparib, which is a PARP1 inhibitor, and then putting them on them, you can see those patients living beyond 1 year. So I think the answer is not like how long to give the chemotherapy or this. I think the answer will be that, do I have a biologic to sandwich or to bring into that regimen, because we know that these metastatic disease, ultimately they grow, and sometimes you lose the opportunity to treat that patient. So I think it is so important to figure out how can we really penalize these targeted therapies, biological therapy, to continue to control the disease, but also maintain the quality of life. Because I always tell people the story of a mini transplant. If you remember, in 1999, Rich Little at NHLBI, the National Heart, Lung, Blood Institute, did a study of mini transplant for kidney cancer. Because the only treatment we have at that time was interferon alpha and interleukin 2. That's it. So then they did a mini transplant where they gave the mini transplant and the patient developed graft versus host disease, and then patients were living at 6 months, and it was the big poster at ASCO, hey, we are making these people. And my question to Rich Little, I was his student, a fellow, I asked him, but the patient is spending 4.5 months in the hospital. So it is really worth giving them 6 months when you spend majority of your time in the hospital. So I think the biggest challenge we as oncologists and hematologists are faced is the quality of life.
Thank you.
Dr. Bhutta.
I have a question for Dr. Wasif. So do we really need to get the KRAS testing before using this drug, number one, brexanosib I am referring to? And secondly, would you be comfortable using it right away, right today, for a frail elderly patient who is ECOG maybe borderline 2 and 3? And what about the early phase development, in early, like in adjuvant or in the first line metastatic setting?
So let me answer your question. I think you have 2 questions, so let's start with the first question. The first question is that, do we really need to check the KRAS, or do we need to give people chemotherapy, or should we go? So I think the way FDA approved this drug, it is approved for patients with pancreatic cancer who have at least received 1 regimen of chemotherapy, or who are not able to tolerate the first-line therapy. So I think that is the kick, because keep in mind in USA I have to document, but then insurance has to approve. And I was just laughing with my colleagues last night because we were so excited that we couldn't sleep and we were talking to each other. And the joke was that we can give people 1 dose of chemotherapy and document that patient cannot tolerate and then go to brexanosib. Because we always make a joke, the USA makes the law and then teach us how to break the law. So that's the answer. But keep in mind that brexanosib, it's a very individual thing again. I can give you an example that some patients will not even accept these drugs because they do not want to have a rash. I have a very young guy, 39-year-old patient with colorectal cancer. I put him on Vectibex and he got very bad rash on the 3rd treatment. He was fighting with me and say, I'm going to stop it. On the other hand, I will have another patient who is on brexanosib. He is full of rash and he says, I don't care. So I think it's a very individual thing, because for some people, cosmetics is a huge thing because they cannot handle it. Now going back to this, the Resolute 3.303, the bill is 304, which is looking at the adjuvant therapy. So that's the good part where the patient gets the neoadjuvant chemotherapy. So chemotherapy, surgery, chemotherapy, and then they'll be randomized to receive brexanosib versus observation. So that study is already going on. So I think the next 10 years it will be all ERS.
Thank you.
Thank you very much, Dr. Saif, Dr. Arshad, and Dr. Zebaziz. And I think we will conclude this session. Thanks.
So, Assalamu alaikum, and thank you everyone for the presence and patience at the same time at 5:15. So, I'm changing the flavor altogether. It's a shift from the drug development and quality assurance to the management of breast cancer. So, we all know that breast cancer has evolved over the years, over the decades, and the shift is toward, I think gone are the days when we say that one fits all. So it's a tailored treatment depending upon the tumor histology, biology, and patient characteristic. So we need to look for more of the approach treatment rather than giving the same treatment for all. Nowadays, we are hearing about the pathological complete responses. This is the term which is used in other cancer, but we are hearing and changing our treatment for the breast cancer. And we all know that being an oncologist, it's not just the patient, it's us who are worried at the same time to offer all the treatment to prevent the early recurrences. But we are aware of our limitation, not only the cost, but also for the resources. So without further delay, I think I would like to invite our next speaker, who
it's a very, very important step that how well they have responded to the treatment we have given them. And then based on those, we give them some adjuvant treatments. So what is the, why it's very important? See, the metastatic breast cancer, 78% of metastatic breast cancer comes from the early stage breast cancer. So it's very, very important. The first treatment patient is getting for the breast cancer, that will translate how that patient will do in the future. And once it becomes metastasis, these patients are not curable. So once the patient comes to you with early stage breast cancer, it's very, very important to follow the paradigm and treat them right. Now, this is actually another diagram showing that these patients, the outcome of these patients, it depends on the treatment they get in the neoadjuvant setting and the response they get on top of that, right? I'll show you some studies in which the responses were as high as 80%, PAT-CR rates were as high as 80%. And even you can see in this slide that even if they have a little bit of residual disease, that it says at the bottom of the slide, even a trace of residual disease requires adaptation of continued therapy. So you have to be very, very mindful of, and even getting a PAT-CR does not mean that this disease will not come back. The chances goes down, but still there are still chances this disease may come back again. Now, these are some of the trials which have shown the PAT-CR rates in neoadjuvant setting. There are a lot of trials. Some of the trials are in the slide. Some of them I did not put on. On the left-hand side of you will see that these two trials shows the breast pathological PAT-CR rate, and on the other side, it shows the total pathological CR rate, which is the breast as well as the axilla. And you can see it ranges anywhere from 60% to in the range of the teens, 17, 20%. And obviously, higher the pathological PAT-CR, higher the overall survival in these patients. And you can see the 5-year event-free survival is in the range of 90%, and 5-year overall survival is in the range of 90%. So very high overall survival. The better the PAT-CR rate, better the overall survival. So hence, we need to escalate our treatment in a high-risk disease, and we need to de-escalate our treatment in the low-risk disease. See, this is the new paradigm in HER2 positive breast cancer. And again, it shows that the high PAT-CR rate does not mean that there is no residual disease. So these are some of the trials. So the trials, the TRAIN trial and the PEONI trial shows that if you are node positive, there is lesser chances of PAT-CR. Similarly, if you are HR positive, there is lesser chances of PAT-CR than the HR negative group. Now, this is actually another practice-changing trial, I believe. Just this indication recently got approved by FDA in the May 2026. This is the Destiny Breast 11 trial. I did not mention the previous trials, which were the standard of care because we're in shortage of time. I will just slightly go on this trial. So this is a trial in which HER2 positive disease, which is high risk. High risk means it can be inflammatory, it can be node positive, or it can be inoperable. These are the three groups which were included in Destiny Breast 5. This is a 3-arm trial. One arm getting 4 doses of Enhertu TDXT, followed by 4 doses of THP. And then there's another arm which just got 8 doses of Enhertu, and the third arm which got the standard of care, which is the dose-dense AC, followed by THP. This was followed by surgery, and based on the results, these patients were treated. If they got the PAT-CR, they got radiation, and they were given trastuzumab plus pertuzumab for a total of 1 year. Remember, these are high-risk patients we are seeing at. This is not the standard risk patients, HER2 positive disease. So it's very, very important that who gets this treatment upfront, we need to know the indications for the treatment in these patients. And the other arm, which did not get PAT-CR, that arm got radiation, and then 1 year of TDM1 for a total of 14 cycles, which is based on the Catherine trial, and I'll talk about that trial. And if they're hormone positive, they get endocrine treatment as per the protocol. And basically, the primary endpoint was PAT-CR rate by the independent review. And the secondary endpoint was PAT-CR by the independent review, EFS, safety, and PROs. And this is actually on intent to treat population. You can see there's a difference of 11.2% in the arm which got 4 doses of Enhertu followed by THP. Similarly, if they are HER2 negative, the response rate went up. The delta was 16.1% versus 9.1% in the HR positive group. And these are the event-free survival curve. The hazard ratio was 0.56. And you can see that the number 96.9% in the arm getting Enhertu followed by THP versus 93.1%. So with this, actually, this is the current paradigm in how we treat our HER2 positive disease. And you can see on the left, we don't give, it's less than 2 centimeter. These patients don't get any neoadjuvant chemotherapy. And then in the adjuvant setting, there are different options. And on your left, this is the right side, sorry, on the left-hand side, you will see that the T2 positive disease or the node positive disease, that's where you get the neoadjuvant treatment. And then based on the results of that treatment, which we see on surgery, we decide, which I will talk about briefly in the coming slides. So what was the basis of Catherine study? So in triple negative disease, in triple negative and other diseases, we are seeing the CREATE-X trial in which after the patient gets neoadjuvant treatment and the patient has residual disease on surgery, capecitabine has shown to improve survival in these patients. And for triple negative disease, it has become a standard of care. Similarly, in metastatic setting, we have seen that patients who are progressing on Perjeta and Herceptin-based treatment, once they progress, Kadcyla becomes the next line of treatment. So based on this paradigm, when we see residual disease, we know that something has to be done for these patients. And what is the drug at that time? It was basically Kadcyla, because these patients have already received Herceptin Perjeta for 6 cycles. So that's why this concept that once they did not get a PAT CR, rather than hitting them with the same drug, try hitting them with this new drug, which has a different mechanism of action. And this led to the Catherine trial. This trial was based on patients who were early stage disease. It included the high risk patients, the node positive patients, as well as inoperable patients also. And at that time, we did not have NHER2. And similarly, they received the completion of neoadjuvant treatment, including the HER2 new treatment, and the surgical removal was done, and pathological evidence of residual disease following neoadjuvant therapy. So RD showed the residual disease, and they were 1-to-1 randomized, 14 doses of TDM1 versus trastuzumab. So they did not get PH, Perjeta, in addition to, in the Catherine trial, it was just trastuzumab. And the primary endpoint was invasive disease-free survival, and the key secondary endpoint was IDFS, disease-free survival, overall survival. And this is actually the 7-year follow-up, the longest follow-up which they've shown. And you can see that at 3 years, 5 years, and 7 years,
So I welcome you all. This session had to be moderated by Dr. Asmina, but she could not join. So let's start the session. And we always wait for the breast cancer session and the abstracts. So our first talk is by Dr. Solmaz Sahibjam. She is a medical oncologist and director of neuro-oncology program at the Johns Hopkins Cancer Center at Sibley Memorial Hospital in Washington. She built her career at Moffitt Cancer Center, where her work on immunotherapy and clinical trials for brain tumors earned her the National Cancer Institute's Clinical Investigator Team Leadership Award. Her focus throughout has been individualized, multidisciplinary care for patients with brain cancer, treatment that addresses not just the tumor, but the patient in front of her. So we'll welcome Dr. Solmaz.
Hello, everyone. My name is Solmaz Sahibjam. I'm a medical oncologist at Johns Hopkins University, and it's a great pleasure for me to speak to you today. I'd like to thank meeting organizers for a kind invitation. I'm going to talk about how the role of ADCs is changing in the way that we treat patients with breast cancer. So at this year's ASCO, there was an update to three large clinical trials which looked at use of antibody drug conjugates in triple-negative breast cancer. And the way that the trend is now in treatment of breast cancer is basically moving these antibody drug conjugates to earlier lines of therapy. And all these three studies basically are doing the same. So one study is ASCENT-03 study, which is looking at sacituzumab govitecan as a first-line therapy for metastatic TNBC. The second is ASCENT-04, which looks at the combination of sacituzumab govitecan with pembrolizumab. And the third study is TROPION-Breast02, which looked at datopotamab deruxtecan for treatment of TNBC. So you are familiar with sacituzumab govitecan. It's an antibody drug conjugate that is against TROP2. TROP2 or trophoblast cell surface antigen 2 is highly expressed in triple-negative breast cancer, and SG is antibody against that. But it's antibody drug conjugate, which also has a payload of SN38, which is a topoisomerase 1 inhibitor. SG has already shown significantly longer PFS in patients whose disease progressed after more than 2 lines of therapy, and right now it's approved in US for these patients with TNBC. So as I mentioned earlier, ASCENT-03 looked at the sacituzumab govitecan alone or chemotherapy alone in patients with previously untreated TNBC who are not candidate for PD-L1 inhibitor. The endpoint was PFS, and patients who had disease progression on chemotherapy could cross over to sacituzumab govitecan. This study was published later last year, and it was a positive study. There was a benefit in progression-free survival. There was a benefit of about 3 months in SG arm versus chemotherapy arm, and there was also increase in duration of response in SG arm in comparison to chemotherapy arm. Most importantly, the incidence of grade 3 and higher adverse events were similar. And when the investigators looked at the discontinuation of treatment, more patients discontinued on chemotherapy arm than SG arm. So at this year's ASCO, there was a presentation looking at biomarker analysis of ASCENT-03 study. At this study, investigators looked at TROP2 expression and see if that affects the response to sacituzumab govitecan. And as you can see here, it seems that PFS benefit from sacituzumab happens in all patients, even those who have lower TROP2 expression. They also looked at tumor BRCA mutation, and as you can see, there was benefit from sacituzumab govitecan in both patients with tumors that they had BRCA mutation and those with with a wild type BRCA. They didn't have data from germline BRCA mutation. And they also looked at HER2 expression. And as you can see, it seems that patients with HER2 IHC0 tumors got benefit from sacituzumab govitecan, and the same with patients that their tumor had HER2 low expression. So based on this, they concluded that basically median PFS was longer with SG versus chemo across all TROP2 expression, tumor BRCA mutation, and HER2 expression subgroups. And it's very important to know that similar data was seen at initial ASCENT study, which looked at SG in patients who had more than 1 lines of therapy for TNBC. The second study was ASCENT-04 study, which looked at, again, the same concept, bringing SG to upfront, to first line of treatment of metastatic TNBC, but these were patients who were eligible for anti-PD-1 therapy. So in this study, SG plus pembro was compared to chemotherapy plus pembro, and endpoint was PFS, with the opportunity for crossing over to SG arm in patients who had disease progression on chemo plus pembro. This study has been also published in New England Journal of Medicine this year, and as you can see, there was a benefit from combination of SG plus pembrolizumab versus chemotherapy plus pembrolizumab. The benefit was about 3.5 months, and there was, again, in this study too, less discontinuation of treatment in SG combination versus chemotherapy combination. At ASCO this year, we heard the same analysis on biomarkers, and here also there was no there was no difference in terms of benefit from sacituzumab govitecan combination, and it seems that all patients benefited from sacituzumab govitecan combination. Although there was a trend towards higher benefit in patients who had higher expression of TROP2 in their tumors, but again, this was more like a study of a smaller sample, and it was retrospective analysis, and that was mostly a trend. Looking at tumor BRCA's mutation, seems that both tumors with wild type and also mutant, there is a benefit here, although in mutant seems that the benefit is not that noticeable, but again, it's a small sample size. But overall, it seems that combination is showing benefit in all tumor types. So the same with HER2 subgroups, no matter if the tumor had HER2 IHC expression of low expression or no expression, there was a benefit of a combination with sacituzumab govitecan with pembrolizumab. So There was also another concept that was presented at this year's ASCO, and they looked at both ASCENT 03 and ASCENT 04 trials in terms of PFS2 and TSST. So PFS2 is basically time from randomization to disease progression on second treatment. So PFS1 is basically from the time of randomization to the time that the tumor progresses on study treatment. Here, then, patients are going on to receive another type of treatment, and that's not part of the study. So in this study, they followed those patients and see that does going on sacituzumab prolongs PFS2? So this kind of analysis has significant statistical flaws. This was discussed at ASCO, and it's always good to know about this. But I'm presenting here because you will see it brought up, so it's good to know about the data. So here they showed the PFS2 on both ASCENT 03 and ASCENT 04 study. On ASCENT 03 study, there was prolongation of PFS2 versus chemotherapy. And as you can see here, of course, on PFS2, we don't know patients who discontinued sacituzumab govitecan or chemotherapy, what was the treatment that they received after, what was the percentage of the patients who received those treatments. So these are the statistical flaws that I was talking about. But what they showed here showed that PFS2 was longer in sacituzumab arm than compared to chemotherapy. And also on ASCENT 04, they showed that the PFS2 was longer in sacituzumab plus govitecan arm, sacituzumab govitecan plus pembrolizumab arm versus chemotherapy plus pembrolizumab arm. And basically, conclusion the authors were making is that that may resolve to OS benefit. So based on the results of ASCENT 03 and ASCENT 04, FDA just recently approved sacituzumab govitecan either as monotherapy or in combination with pembrolizumab for first-line treatment of TNBC here in US. So that's one of the treatment strategies that now we have, and we can start as a first line in these patient population. The third study that I'd like to talk to you about is the study that looked at datopotamab deruxtecan or Dato-DXd. Dato-DXd is another TROP2 antibody drug conjugate, and the difference here is that the topoisomerase inhibitor payload is DXd. So has still the same mechanism as topoisomerase 1 inhibitor, but there's a different payload, and that's DXd. Dato-DXd has been already approved in US for hormone receptor positive, HER2 negative advanced and metastatic breast cancer after progression on endocrine and chemotherapy. And TROPION-Breast02 looked at this agent of first line for patients with advanced or metastatic TNBC who were not eligible for immunotherapy. And they compared Dato-DXd to investigators' choice of chemotherapy. And the endpoint was PFS and OS. This study was published recently on Annals of Oncology and showed PFS benefit. As you can see here, patients who got Dato-DXd had a longer PFS. The median PFS was about 5 months longer here. And they also showed OS benefit. Here there was OS benefit of about, again, 5 months in patients who got Dato-DXd. And based on this, FDA approved Dato-DXd for unresectable or metastatic triple-negative breast cancer for first line, and we have this option, again, approved this year at US. And at ASCO, there was again a presentation covering the PFS2 and TSS-T on this study, looking at progression-free survival after basically starting from time of randomization and continuing even after the recurrence on the study drug. And as you can see, it seems that patients who were on Dato-DXd, they had a longer time to first subsequent therapy or death on this agent when compared to chemotherapy. So basically telling us that maybe these patients stay on these drugs for longer and also the disease is better controlled. And the time to second progression was also longer. So again, here it comes with the caveat that we don't know what was the second line of therapy, what was the percentage of the patient who received the therapy on each arm. But again, this points that maybe this leads to the OS benefit in patients who start Dato-DXd as a first line of therapy. So in conclusion, what we heard this year at ASCO tells us that both sacituzumab govitecan and datopotamab deruxtecan, two TROP2 ADCs with topoisomerase 1 inhibitor payload, show significant PFS benefit in first-line therapy of patients with advanced or metastatic TNBC, bringing these agents to first line of therapy, and of course being one of the options that now we have for treatment of these patients. Thank you.
So next we have Professor Étienne Brain. He is a medical oncologist at the Institute in St. Cloud, France, where he has practiced since 1998. He's one of the leading voices in breast cancer and geriatric oncology. And currently he serves as Secretary General of the European Organization for Research and Treatment of Cancer. He's a past president of the International Society of Geriatric Oncology, and in 2022 received American Society of Clinical Oncology's Kennedy Award for Scientific Excellence in Geriatric Oncology. So let's start.
Étienne Brain, a medical oncologist working at Institut Curie in Saint-Cloud and Paris in France. And I'm very pleased to be here to speak about breast cancer in the older ones in order to balance benefit and burden. I'm very grateful to the organizer to have invited me to speak about this at this important event organized around ASCO and ASCO results. This is my usual slide of conflicts of interest and why this topic is important. This topic is important because there is a very common shortcut in statistics, which makes that the left panel, which is this one in 8 women developing breast cancer, is very biased because this is this one which is very common, the right panel, since breast cancer risk increases with age, and it is very common above 70. 40% of breast cancer cases occur in older patients from the age of 70 in Western countries, and especially in Europe. Making that when you deal with oncology in general, in adult patients, you are a geriatric oncologist, and you just do not know it yet very often. The crux of the management of older ones with cancer in general are the competing causes for mortality. And if you look at breast cancer, a sizable proportion of older patients with breast cancer die of non-cancer related causes, and that happens from the age of 70. You see that almost 50% and above, that's all this segment, die of non-cancer related causes. So requiring that you introduce some hierarchy in the way you treat these patients. Behind, this is a concept of intrinsic capacity, which is the functional reserves of patients, of the population. And you see that these functional reserves decline according to time. They start declining from the age of 30, actually. And according to time, under the stress, which can be a disease like a cancer or a treatment or a fall, frailty may appear, and from which one recover sometimes very hardly, which is called resilience. And it's not rocket science to understand that a patient fit and a patient frail can be or seem very similar, but the right one will have much difficulty if you remove one block of Kaplan on this slide, because if it happens, it will tumble down and the recovery will never allow to go back to the prior status. So frailty, it is a concept which you can assess through different scales. For example, you can use the Fried frailty phenotype or the frailty index by Rockwood, but it's a very common phenomenon that you see in patients above 70, which increase with age. Aging boost progressively the incidence of frailty, but from the age of 70 or 75, you see that you reach up to 30 to 40% of all comers outside of cancer who present some level of frailty. In breast cancer, the incidence of frailty is important. If you look for it, for example, with a screening tool for frailty, which is the G8, has been developed in France, you find frailty in 40% of all comers with breast cancer in adjuvant setting from the age of 70. That's the result of ASTER-70, a large trial, very inclusive, which has been run between 2012 and 2016. We'll speak about it later a bit more. And in metastatic setting, you find up to 70% of older ones from the age of 70 who show some symptoms of frailty. At the same time, we are very short of very objective and scientific data regarding this population. Actually, who get cancer? Older ones. They represent more than 50% of patients with cancer. And unfortunately, they represent less than 10% of patients in clinical trials. And this has not changed in 2 or 3 decades. If you look at the numbers from the NCI sponsored treatment trials, all these numbers have not changed or hardly changed across 2 or 3 decades. Even recently, in the specific trials for breast cancer in post-neoadjuvant setting like X or Catherine, you see that you didn't have any patients above the age of 65 or 75 in this trial. And with the ADCs like sacituzumab govitecan or TDXD or Pembro in KEYNOTE-522, the representation of older ones above 65 sometimes can give you the illusion that you have a few ones, but actually from the age of 75, which is so common for the older population, you find hardly 1 or 2% of the patients in these trials above this age. And in CDK4/6 inhibitors registration trials for EBC, you have exactly the same issue. If you take, for example, Monarchy, you had only less than 3% of patients in these very large trials who were above 75. So that creates a very important bias in terms of results and how you apply these results to the standard population aging and older than 70. This is especially true because the trial population actually are the older ones enrolled in these trials belong to this segment, the lower segment. They are much younger than the standard older ones, with less comorbidities, with less organ dysfunctions, and much fitter. So it's a double pain in terms of, or double discrimination regarding this population. However, although it is the main population of what we see in routine. Why is it a problem? Because behind the tolerance to this, the more the treatment you consider is aggressive in terms of side effects, the more risk you take in terms of decline of functionality and on impact on quality of life. And if you look at adjuvant chemotherapy, from the age of 65, as a CLGB data, the 49907 trial, you see that across a subgroup, which was analyzed according to functionality, these older ones showed a decline in 40% at the end of chemotherapy in terms of functionality. And of them, half of them never recovered, actually, at 1 year, and to which we should also add those who didn't decline at the end of chemotherapy, but who declined at 1 year. So in total, 30 to 40% of these older ones have an acceleration of aging under treatment, and that should be an important top information to share with them in terms of treatment decision making, in terms of shared decision. And so we have this difficulty to identify and to support the use of aggressive treatments, and adjuvant chemotherapy is a very good example. If you look at the Oxford meta-analysis across 2 decades of papers, adjuvant chemotherapy seems to work irrespective of age. You see that the 70 plus population is here, the blue bar, but the magnitude of effect on recurrence or death is much lower compared with younger ones, and especially with confidence interval very wide. And it is due because of the representation of older patients in these overviews of chemo versus nil, or dose then chemo versus standard chemo, or the use of sequential treatment. You see that the representation of older ones is very limited. So how can you rely on robust conclusions to apply these strategies, which have been very, or most of the time, studied in younger ones? And you can look that from another slant, another angle. If you look at the relative dose intensity, which is a kind of graal in oncology, especially in the adjuvant setting, with a threshold of 85% being required to expect a true benefit from your strategy, you see that age has an impact of getting a poor relative dose intensity, and the treatment duration, meaning that behind you have a question of whether 3 months or 6 months is the same or different, and can you use what we use in younger ones, which is very often extended. And you see that in these older ones, TC was the TC regimen had the higher relative dose intensity, while if you look at sequential chemotherapy, it's almost half of what you get in terms of relative dose intensity, correct, adequate. And so that question a lot on how you use the regimens developed in younger ones to the older ones with no consideration. Another way to look at this, stressing the need to adjust treatments and not use what you use in younger ones, is a specific algorithm developed by the Cancer and Aging Research Group at the City of Hope on older ones from the age of 65, where they identified treatment duration above 3 months as a very important weight in the risk prediction of grade 3 and 5 adverse events. That's the factor which has the highest contribution to the risk as a fall in the last 6 months, a geriatric syndrome. All that stress means that behind we have many many hints or many signals come from trials and from real life data showing that we need to adjust. For example, at TRITC, we ran this trial in metastatic setting, looking at the first line of systemic treatment for HER2-positive disease above 70, and looking at a different approach than the standard, or until recently, the standard line, which was a Cleopatra regimen, taxanes plus 2 antibodies. We randomized 1-to-1 the use of the 2 antibodies alone and the 2 antibodies with a much milder regimen in terms of chemotherapy, which was metronomic cyclophosphamide. And we demonstrated that we could do very good with this kind of lighter regimen, always a bit better than pertuzumab, trastuzumab, but this one was doing very well also in terms of quality of life. And so we have alternative to what we do in younger ones for this older population. Another aspect is the use of adjuvant chemotherapy for luminal disease. And in this high-risk disease, above 70, we randomized 1-to-2 the use of adjuvant chemotherapy followed by endocrine treatment, or no adjuvant chemotherapy, but endocrine treatment plus CDK4/6 inhibitors for 2 years with palbociclib. 400 patients randomized 1-to-2, and the primary endpoint, the 3-year distant relapse-free interval. And the first result will be presented in San Antonio at the end of the year. That shows you that we can try to identify real alternative to aggressive treatments for this population. And more recently, with the Keynote 5-2, there is this multi-center real-world study run in Brazil and Argentina, which shows that these older ones, in this large study, 700 patients, only 80 above 65, but these 80 had a lower PCR rate in terms of neoadjuvant strategy results, but a higher toxicity burden, treatment discontinuation, dose reduction, delays. So distinct biological and clinical features and increased toxicity burden. So we cannot treat these older ones exactly the same way. And we have a few guide or tools to help us to treat better this population. One such is the age gap decision tool developed by UK, based on almost 40,000 cases of patients above 70, and incorporating tumor age, comorbidities, and activities of daily living. And across this situation, if you take a scenario of an 8-year-old lady with a luminal disease, 2-node positive, and some ADL restrictions, some comorbidities, you see that applying chemotherapy at 2 years and at 5 years, you increase in terms of breast cancer specific mortality, you improve by 1% the result at 2 years and by almost 2% at 5 years. But what is very important to identify is that the vast majority of deaths are due to non-breast cancer causes. They are 8 times higher in terms of deaths compared with breast cancer deaths. In blue, breast cancer deaths, in yellow, non-breast cancer deaths, and you see that whether you give chemo or no chemo on the left, chemo on the right, at 2 years, at 5 years, you do not see a big difference. So that reintroduces a question of proportionality of cares and on which we should pay attention. And we should pay attention to that because what is provided by clinical trials, for example, if you take Monarchy, a very similar disease that we, for very similar cases that we just discussed with chemotherapy, the use of abemaciclib in adjuvant setting, in clinical trials highly selected at 2 or 5, or at 2 years or 3 years, you see that whether you gave abemaciclib or only endocrine treatment, you have, of course, a better control on deaths due to breast cancer in blue, but the breast cancer deaths are 4 times higher than non-breast cancer deaths, which means that you take a trials on the right and you see this balance in terms of breast cancer death versus non-breast cancer death, and it's totally the opposite when you look with on a specific series, specific registries, specifically built for older ones with an algorithm. So that creates many questions regarding how we apply standard developed from trials, highly selected, in a younger population to the older ones. So just to stress. And the last example that I would like to show you is the ASTER-70 trial, which looked at adjuvant chemotherapy versus no adjuvant chemotherapy in women above 70 selected with a genomic grade index. This large trial randomized in phase 3 was published in The Lancet last summer and was unable to identify a significant, statistically significant benefit provided by chemotherapy in laminal disease. And of this patient, very importantly, 40%, as you see, had some level of frailty. They were all comers across France and Belgium, and this trial failed to show that based on a sample size of 1,200 patients, roughly, but screened from 2,000. And this trial had no difficulty to recruit. So that shows you how it is difficult to apply what we develop in younger ones so easily in older ones. Older ones, main population, flagrantly underrepresented in trials, which never take into account multi-complexity and competing risk. So high risk uncertainties with the plus oncology model on treatment intensity. And on the other side, implicit importance of endocrine treatment above chemotherapy and guidance issues because they are not part of clinical trials developing this alternative to chemotherapy, for example. And last but not least, these older ones are very often left behind in terms of the development of digitalization or, for example, electronic patient-reported outcomes. In this trial, run in France in rural areas, almost 500 patients, older patients, to whom was offered this investigation of reporting treatment outcomes through an electronic device. Actually, 60% of refusal, but mostly for technical barriers, which were internet access, uncomfortable to use internet or connected apps, and technological barrier, making the feasibility of this development in terms of techniques very low. One out of 4 patients only in these older ones. So at the end, we are between these balanced positions that we need to reach and which requires the use of this collaboration between oncologists and geriatricians to avoid nihilism or blind therapeutic enthusiasm in older ones. And for which geriatric assessment is a high level of evidence, 1B grade A, guiding cancer treatment in older ones. It is purely integrative medicine. When you implement this information, you change the oncological plan in 30 to 40% of cases with 2/3 of de-escalation and with a positive impact on treatment completion, toxicity, quality of life, etc. We have plenty of high-level randomized trials which have demonstrated very clearly the impact of this management. Of course, the future is probably in the biological test to assess life expectancy, intrinsic capacity, and impact of treatment on aging and anticipate accordingly. But the candidate markers are not ready for prime yet, but we are working intensively on it. However, frailty is a very important concept and should be measured at baseline and as an outcome in drug trials, especially for any cancer, but the breast is part of it. And the pragmatic approach should be based on a screening tool like the G8, and we should have specific attention to cognitive impairment as well. So I'm going to just to highlight, for example, what we try to do at EORTC level with Unicancer, which is revisiting the concept of neoadjuvant treatment, which is such an important strategy for TNBC and HER2-positive disease, and to which extent it applies well to vulnerable patients above 70 is a question mark. And so we have this program, which is going to look in patients above 70, presenting it with a G8 below 14 and a T2 or T1 CN1 and 2 TNBC or HER2-positive disease, neoadjuvant approach versus an adjuvant approach after surgery upfront, and exploiting the concept of post-neoadjuvant treatment in the group submitted to a neoadjuvant strategy. And we want to demonstrate that they can derive benefits, they can participate to innovation, they can also benefit from this approach to improve breast-conserving surgery without impacting necessarily on the functionality of these older ones. We have updates. We have recommendations on the management of older ones with breast cancer developed principally by the International Society of Geriatric Oncology. They are updated every 5 to 10 years. The last update was published in 2021. And all that is to say that age is not a contraindication to treatment but nor to clinical trials. And we need to make a great effort in terms of research for this population. And at the same time, age is an independent predictor of adverse events or outcomes associated with treatments especially when we rely on results from trials run in younger adult population. That means that we cannot continue treating patients older or older than 70, 75 based on standard guidelines developed discriminately in younger ones and then applied with no considerations to older ones who have not participated to the research. We know that there are too many risks, too many requirements in terms of dose adjustment, attention to pay in terms of quality of life, and all that needs to be introduced in the process of shared decision-making in breast oncology. Thank you very much.
So next talk is by Dr. Rob Stain. He's consultant oncologist at University College London Hospital and UCL Research Department of Oncology, where he has practiced since 1997. He's a leading authority on personalizing breast cancer treatment, best known as chief investigator of the OPTIMA trial, a major study using genomic testing to guide chemotherapy decisions in early breast cancer, alongside his work on the PACT and ROSCO trials. So he'll be talking about updates about the results of OPTIMA trial.
Thank you for inviting me to present the OPTIMA results at your Best of ASCO meeting. I have to start by apologizing for not being able to join you in your beautiful city of Lahore today. I'm going to show you a slight update on the presentation of the results from Chicago in May. So, to start at the end, the OPTIMA trial has demonstrated that 50-gene prosigna test identifies a group of about 2/3 of patients with ER-positive, HER2-negative early breast cancer who do not have a meaningful chance of benefit from adjuvant chemotherapy. Our study population included women aged 40 or older and patients with up to 9 involved lymph nodes. In the next few minutes, I'm going to show you how we reached that conclusion. We've all become used to using tumor gene expression tests to assist adjuvant chemotherapy decisions. Their main use is for postmenopausal patients with 0 to 3 involved lymph nodes. Supporting evidence for use in premenopausal patients is mixed, and there's almost no data for patients with more than 3 involved lymph nodes. The OPTIMA trial is a prospective RCT of test-directed versus standard treatment. We chose a 50-gene prosigna test to make chemotherapy decisions following an analysis of our pilot trial. The trial hypothesis was that the number of involved nodes would not affect chemotherapy response for low test score tumors. We therefore chose a Prosigna risk of recurrence, or ROR score cutoff, of 60 as the upper limit for endocrine therapy alone. Scores above this are characterized as high risk if node negative. This slide shows how the Prosigna test works. Underpinning the test is the intrinsic subtype classification of breast cancer, represented by the expression of the PAM50 gene set, and divided into 4 basic intrinsic subtypes: luminal A, luminal B, basal-like, and HER2 enriched. And an individual tumor gene expression profile is correlated with the archetypal pattern of each of those 4 subtypes. And that information is combined together with an adjustment for proliferation and for tumor size to give the primary output of a test, which is the risk of recurrence score, which is an integer in the range of 0 to 100. This is the optimal design. The main eligibility criteria were women and men aged at least 40 with excised breast cancer, and with up to 9 involved lymph nodes. Patients with node-negative disease or micrometastases only were required to have a tumor of a minimum size of 20 to 30 millimeters. Neoadjuvant chemotherapy was prohibited. Consenting patients were randomized 1-to-1 between the control arm and the test-directed arm. In the control arm, patients received chemotherapy followed by endocrine therapy, chemoendocrine therapy. Patients in the test-directed arm had a tumor Prosigna test. Those with a high score, i.e. an ROR greater than 60, received the same chemoendocrine therapy as patients in the control arm, whilst patients with a low ROR score received endocrine therapy alone. Patients receiving chemoendocrine therapy were blinded to their randomization, and we did not disclose the results of their Prosigna test. Patients who were premenopausal and receiving endocrine therapy were treated with ovarian function suppression. All other treatment was standard of care. We performed Prosigna tests in control arm patients, which we used to help the analysis, but not for making any treatment decisions. So OPTIMA is a non-inferiority trial. The primary endpoint was invasive breast cancer-free survival, which includes all invasive recurrences, new primary breast cancer, and death from any cause. The trial was powered to demonstrate 3% non-inferiority after 5 years. We consulted patient groups and clinicians at the design stage who considered this was acceptable. The primary analysis was performed in the per-protocol population to minimize the risk of a false non-inferiority conclusion. The comparison between test-directed and control arms was intended to facilitate a health economics analysis, which we hope to present in October at the ESMO meeting. The key secondary analysis was a comparison between patients with a tumor ROR score of 60 or less, which is in effect a randomization between chemotherapy, chemoendocrine therapy, and endocrine therapy alone. This slide shows trial flow. We recruited 4,429 patients from 6 countries between January 2017 and December 2025. If you concentrate on the grey boxes, we lost about 2% of our patients between randomization and treatment allocation, mostly because they had second thoughts. There was a further loss before the start of treatment, again, mostly because patients rejected their assigned treatment, particularly chemoendocrine therapy. Therefore, the final per protocol population was 93% of the intention to treat population in the control arm and 94.6% in the test-directed arm. The eagle-eyed amongst you will notice that there were a very small number of patients with either ER negative or HER2 positive disease included in the final analysis population. These were discovered as a result of the ProSigna test, and as they make no difference for the trial result, I'm not going to elaborate any further. This graph shows the distribution of tumor ROR scores in the control and test arms. They're very similar, but just under 2% more patients in the test arm than the control arm had a low-score tumor. And this table summarizes the per-protocol population characteristics. The first thing to say is that although this is not the intention to treat population, the two arms are very well balanced. So concentrating on the combined population, in the right-hand column, the median age was 56 with a range of 40 to 84. 37% were premenopausal, 0.8% men, about 70% had a grade 1 or mostly grade 2 tumor, nearly 50% had a tumor size greater than 30 millimeters, and about 75% had 1 to 3 involved lymph nodes, with almost 20% 4 to 9 involved nodes. And so to the updated results. This table summarizes events in the two trial arms. The left-hand two columns show the full protocol population, and on the right, the low ROR score group. Most events in all four groups were distant breast cancer recurrence. Proportionally fewer of these occurred in the low ROR score group, which is to be expected. To date, there are fewer non-breast malignancies in the control arm than the test arm. This is not included in the IBCFS definition, but the pattern is perhaps reflected in deaths, although there are currently too few of these to draw conclusions. This is our key finding. The Kaplan-Meier curve to the left is a full per-protocol population, and to the right, the low ROR score population. There's no difference between trial arms. We met the predefined non-inferiority test with p-values of 0.006 and 0.003 in the full and low ROR score populations. Both results are in fact consistent with 2% non-inferiority. The 5-year point estimates of chemoendocrine therapy benefit is 1.5% in the full population and 1.2% in the low ROR score population. I'm also going to show you distant recurrence-free interval at this stage. This is defined as distant recurrence or death from breast cancer. The slide format is the same as the previous one, although we have not performed any significant tests. And the result is very similar to the IBCFS. The 5-year point estimate for chemoendocrine therapy benefit is 0.8% in the full population and 1% in the low ROR score population. Confidence intervals are inevitably broader than for the IBCFS analysis. The next few slides concentrate on the subpopulation with low ROR scored tumors. This is the forest plot for the pre-specified subgroups, and there's no evidence of any heterogeneity within these. Moving to 3 subgroups of particular interest, this shows Kaplan-Meier plots of IBCFS for premenopausal patients to the left, who make up 40% of the analysis population in this slide, and postmenopausal patients to the right. There's no difference. These are the Kaplan-Meier plots according to the number of involved lymph nodes, 1 to 3% in the left, and 4 to 9% on the right, which is 18% of the population. There's no difference. I point out that the number of patients in the 4 to 9 lymph node involved group is quite small. And because we recruited a significant number of patients with large tumors, we also looked at TNM stage groupings, as you can see here. Stage 3A, which is to the right, included all patients with 4 to 9 involved nodes and patients with any lymph node involvement and a tumor greater than 5 centimeter diameter. And so this group made up 29% of the analysis population. And again, there is no difference between the results. This final slide summarizes the 3 sensitivity analyses we performed. All 3 were in the intention to treat rather than per protocol populations. The results are consistent with the per protocol findings. The first 2 use the IBC-FS endpoint in the full population and the low ROR score groups. The third uses invasive disease-free survival endpoint, which includes all IBC-FS measures together with second non-breast cancers. This is how the trial was originally designed prior to the recommendation to use IBC-FS for non-inferiority studies. Optima, like all trials, has limitations. The biggest is that there is limited follow-up with fewer than 40% reaching 5 years, which means our confidence intervals are currently relatively broad. This mostly affects subgroup analyses. We know that most of the effects of chemotherapy on recurrence are expected in the first 5 years, so follow-up beyond that point will not add to the certainty of our result. 90% of our participants describe themselves as white, and whilst this reflects the characteristics of the population we recruited from, it does mean that we cannot say much about Prosigna use in non-white populations. And I point out we did not recruit patients younger than 40, and the cost-effectiveness analysis is ongoing. There are a couple of discussion points I have to make. Firstly, breast cancer in younger versus older premenopausal patients may not be the same even after correcting for known prognostic factors. Ongoing trials will develop additional information about young patients. The EBC-TCG meta-analyses have consistently shown that the ER-positive, HER2-negative population benefits from chemotherapy. If, as we have shown, 2/3 of that population does not benefit from chemotherapy, then this implies that the benefit in the remaining 1/3 is larger than we are accustomed to thinking. So, in conclusion, we have shown that patients with low ROR score tumors gain minimal, if any, chemotherapy benefit. Whilst our result applies to our entire population, we've shown that Prosigna can assist safe adjuvant chemotherapy decisions for premenopausal patients aged at least 40 and treated with ovarian function suppression, and patients with 4 to 9 involved lymph nodes or stage 3A tumors. Both of these findings are new. The trial team has a huge number of people to thank for the success of Optima. Firstly, there are the patients and their families and supporters. Then there are the many staff at our recruiting and coordinating centres. And finally, there are our funders and their supporting organisations. And I single out Independent Cancer Patients' Voice, who have been involved with this project since its inception. Thank you.
So for abstracts presentation, I'd like to call Dr. Saad Naviwala. He's a consultant medical oncologist at Cancer Foundation Hospital, and he currently serves as a treasurer at Recon.
Assalamu alaikum and good morning, everyone. Good evening, everyone. My name is Dr. Saad Naviwala. I'm a medical oncologist at Cancer Foundation Hospital. I'll be presenting 3 abstracts from for the Best of ASCO 2026 that are practice affirming and practice changing. So I'll start with the first one. So the first one is the HER2 CLIMO-5. I'll be presenting efficacy and safety of tucatinib versus placebo combined with dual blockade as a maintenance therapy in HER2-positive metastatic breast CA in specified stratified subgroups. It was presented by Dr. Erica Hamilton. So as we know, the first-line treatment for HER2 metastatic breast CA is the induction chemotherapy with the taxane with dual blockade, Herceptin and Perjeta, followed by maintenance. But unfortunately, within less than 2 years, there's a recurrence. So optimizing first-line treatment therapy by HER2-targeted therapy, both extracellularly with dual blockade monoclonal antibodies and intracellularly with tucatinib may further improve patient outcomes. So this is the HER2 CLIMO-5 design, in which they took all those patients who are HER2-positive metastatic breast CA patient who have received 4 to 8 cycles of THP with no evidence of progression. They were stratified in 1:1. The experimental arm received tucatinib 300 milligram BID along with dual blockade plus minus endocrine therapy, and the standard of the control arm received Herceptin and Perjeta along with the placebo with endocrine therapy. The primary endpoint were the progression-free survival. The secondary endpoints were the overall survival, PFS as per the BICR, CNS progression-free survival, safety, quality of life, and pharmacokinetics. Okay, so this is the PFS in overall population. As you can see, the curve started to separate from the beginning and remained separated till the end. There was a PFS difference of 16.3 versus 24.9 months with a difference in magnitude of about 8.6 months. They were better in overall response rate. There was lengthening of overall response rate from 15.2 to 22.8. And in the median duration of response, it was 16.9 versus 20.9. They further evaluated further subsets of patients who were hormone positive versus hormone negative, with brain mets versus without brain mets, and de novo versus recurrent. So what we see in these patients that both hormone positive and hormone negative patients get benefit. It was about 6.9 months in hormone positive patients and about 12.3 months in hormone negative patients. There was then they further evaluated hormone receptor positive patients that received endocrine therapy, and by surprisingly, what they saw was that there was a same response in both these patients, those who have received endocrine therapy and those who haven't. There was a delta magnitude of 2.2 months difference in that. Coming on to the patients who had a brain mets, about 12.4% of the patient had brain mets, and there was a doubling of PFS from 4.2 to 8.5 months, whereas those patients who didn't have brain mets, they also had a lengthening of PFS. Coming on to the recurrent versus de novo metastatic breast CA, we saw the same effect in progression-free survival. Coming on to the safety and side effects, the safety profile was similar in both the arms, and their discontinuation rate was also similar. So the key takeaways was tucatinib as a first-line maintenance therapy with trastuzumab and pertuzumab demonstrated clinically meaningful efficacy in all the subgroups, whether it was HR positive or HR negative, with or without brain mets, or de novo or recurrent metastatic disease. Results were consistent with the overall population and support of tucatinib with dual blockade as a potential new maintenance therapy across patients with HER2-positive breast CA patients. Coming on to the second trial, this is for our surgical colleagues. So omission and completion of axillary dissection in patients with breast cancer and central lymph node macrometastasis. So I'll be presenting CENOMEC trial, the overall survival and patient-reported arm morbidity. So as we all know that axillary lymph node dissection carries a significant morbidity and arm-related complications than axillary lymph node biopsy. randomized trial, for example, Z11 and Ambros, showed non-inferior survival rates when omitting the complete axillary lymph node dissection. They lacked statistical power, they failed to include relevant clinical subgroups, and they varied or failed to report nodal radiotherapy target volumes. So CINOMEC was a randomized non-inferior trial. They included 3,000 patients, and less than 200 patients were required for the statistical power. Non-inferior margin was about 2.5%. The primary endpoint was the overall survival. So the patient underwent upfront surgery, either mastectomy or breast conserving surgery, followed by sentinel lymph node biopsy with 1 to 2 nodes, and were randomized in 1:1 fashion. So half of the patient received complete axillary lymph node dissection, and half of the patient underwent omission of axillary lymph node dissection, followed by adjuvant treatment as per the standard of care, including chemo, radiation, and hormonal treatment. They included T1 to T3 lesions. 1 to 2 sentinel lymph node macrometastasis was the major cutoff for these patients. For those patients who are clinically node negative, mandatory preoperative ultrasound was done, breast conserving surgery and mastectomy was included in this trial. And there were no medical contraindication to any adjuvant radiotherapy or clinical relevant systemic treatments. Patient-reported outcomes were evaluated through EPS at 1, 3, and 5 years. There were 3 questionnaires that were filled for quality of life, arm symptoms, and physical function. 5 European nations were included from 2015 to 2021, and they included T3 patients also that were about 5.8%. Mastectomy was done in 36% of the patients, and interestingly, 87% of the patients were ER positive, HER2 negative. Coming on to the axilla, so about 85% of the patient had 1 sentinel lymph node, about 10% of the patient had micrometastases, about a third of the patients had an extranodal extension, and the non-sentinel node metastasis was about 34.5%. Coming on to the recurrence and death, so local recurrence and regional recurrence was very low and comparable in both the arms, whereas distant recurrence and death was comparable in both the arms. Coming on to the secondary endpoint, primary endpoint, that was the 5-year overall survival. As you can see, the graphs that are hugging each other and overlapping each other. So it was about 94.4% in omission versus 93.4% in complete axillary lymph node dissection. Coming on to the secondary endpoint, that was recurrence-free survival and breast cancer-specific survival, that was also comparable in both the arms. Coming on to the quality of life, it was better in sentinel lymph node biopsy, arm symptoms were better in sentinel lymph node biopsy, and physical functions were also better. So, the arm physical function at 5 years, severe and very severe problems were about 13% in complete axillary lymph node dissection and about 3.6% in omission of the complete axillary lymph node dissection with a significant p-value. So the conclusion would be that the omission of completion of axillary lymph node dissection result in significant less arm symptoms, better quality of life, and better arm physical function. Omission of completion of axillary lymph node dissection should be the standard of care in breast cancer that has spread to 1 to 2 sentinel lymph nodes. This recommendation should be viewed in context of the adjuvant locoregional therapy, which most patients in CINOMEC received. Then there is a new trial that is ongoing. Omission of locoregional radiotherapy is evaluated in that ongoing T-REX trial. Coming to the last trial, that is the SERENA-6, and I'll be presenting the final PFS2 data here. It was presented last year at ASCO 2025, and I'll be presenting PFS2 data. So as we all know that camizestrant is an oral SERD, and it completely antagonizes the estrogen receptor and designed to inhibit and degrade mutant as well as wild type androgen receptor. SERENA-6 investigated a proactive switch in treatment to camizestrant while continuing the same CDK4/6 upon detection of ESR1 mutation to address the emerging resistance before the disease progression. I'll be presenting the PFS2 results. So this is the trial schema. As you all know that they included all the patients were ER positive, HER2 negative, advanced breast cancer patients who were on CDK4/6 inhibitor along with aromatase inhibitor for at least 6 months. They were randomized. About 3,000 patients were included in this trial. 500 were, ESR1 mutation was detected through ctDNA every 2 to 3 months with no evidence of disease progression. From 3,000 patients, 500 were had an ESR1 mutation, and out of that, 315 were asymptomatic. So they were randomized in 1:1 fashion. The standard arm, the experimental arm received camizestrant 75 milligram once a day with CDK4 and placebo, and the control arm received AI with CDK4/6. The primary endpoint was the progression-free survival, and second endpoint was the PFS2. So this is the updated PFS2 at 23.5 months. It was about 9.2 versus 16.8. And the final PFS2 was also increased from 19 to 25 months. The overall survival data is still immature, whereas the chemotherapy ADC-free survival was increased from 18.7 to 22.6 in the camizestrant arm. The total ctDNA levels substantially reduced in the camizestrant arm. It was about 51% reduction in the camizestrant arm versus 2% in the AI versus CDK4/6. So that's all. I'll be concluding it. So PFS benefit from switching to camizestrant with continuation of CDK4/6 at ESR1 mutation emergence and ahead of the disease progression is confirmed. The absolute median improvement has increased to 7.6 months. PFS2 was about 6.6 months. Switching to camizestrant extends chemotherapy ADC-free survival and reduces the risk of deterioration in patient-reported cancer outcomes. And it also decreases the ctDNA levels by 51%. Thank you.
So next we have Dr. Maria Guptia. She is consultant medical oncologist at Shaukat Khanum Hospital, Peshawar.
Thank you, Hira. And thank you, SMOP, for giving me the opportunity to speak at this forum. So I'll be going ahead with further abstracts. So this is my disclaimer. So the studies that I'll be discussing are further updates of ASCENT-4 study, the Persevera trial, and REDUCE trial. So coming on to ASCENT-4, so this was a phase 3 trial of sacituzumab govitecan plus pembrolizumab. And it compared that in patients who were PD-L1 positive and had metastatic triple-negative breast cancer, how were the outcomes of this combination? So the patients could be de novo metastatic or could have had treatment completion more than 6 months after treatment with curative intent. And the primary endpoints were PFS, OS, and safety. So these were the major takeaways from this study, that this combination proved to be effective. So let's go into the details. We know from the primary analysis of ASCENT-4 trial that the PFS was significantly better in patients who were treated with this combination. But the OS data is still immature. And in a study population where around 81% of the patients were allowed to have a crossover to sacituzumab govitecan plus pembro, it's very important to look at other parameters other than OS, and PFS2 proves to be one of them, which can tell us about the clinical benefit of the combination. So this is the definition of PFS2. It is the time from randomization to second progression or death, whichsoever occurred first. So the baseline characteristics, we know they were very well balanced. So in these trials now we are seeing that there is better representation of Asian and non-white populations. So we can then probably extrapolate to the data to our populations as well. And it's very important to note that at the time of this analysis, there were almost twice the more patients on the SG plus pembro group who were still receiving therapy. And another important thing is that there were around 81% of the patients in the control arm who went on to have SG in subsequent lines of therapy. No additional safety signals. So this is the main graph showing the PFS2. So we can see that the curves are separating nicely, and the median PFS was not reached versus 21 months in the control arm. So the key takeaways from the ASCENT-4 study were that SG and Pembro combination showed a better PFS too, despite the fact that there was a significant population who received SG in subsequent lines of therapy. Hence, this data further supports that SG plus Pembro can be a new first-line standard of care in patients who are PD-L1 positive and have metastatic TNBC. The next study that I'll be discussing is Persevera trial, which was a trial on the efficacy of giredestrant plus palbociclib against the current standard of care, letrozole plus palbo, in patients with advanced metastatic hormone receptor positive breast cancer as first-line therapy. So the key takeaways were that this combination, it showed numeric benefit in terms of PFS, but failed to do so in terms of statistical significance. Tolerance was fair enough, and further exploration is required to see the specific subset of patients who would benefit from this combination. So the background. So we know that this is a new drug. Still, the FDA has not approved it, but this is an oral SERD. So if you look at this diagram, you can see that giredestrant blocks the ER by two mechanisms. One is by blocking ER directly, and other is by causing degradation of ER. And once this is combined with CDK4/6 inhibitors, which are the downstream signaling pathway inhibitors, so this can prove to be very effective. So now, do we have any previous data? So there are two trials. One is called lidERA trial, in which they looked at the role of giredestrant in adjuvant setting, and there was found to be superior efficacy. And the other trial was AVERA, in which they looked at the role of giredestrant plus everolimus in those patients who had progressed after receiving initial CDK4/6 combination. And again, here it was found to be of superior efficacy. So it was important to see that does this combination, that is replacing the AIs with giredestrant in first-line setting and combining them with CDK4/6 inhibitors, would that be effective or not? So in this population, they selected these patients who had evidence of either upfront metastatic disease, or their disease has progressed within 12 months or after 12 months. So this was the main stratification which was done. The 992 patients were randomized to receive giredestrant plus placebo plus palbociclib versus the standard of care, and the treatment was to be continued till progression or unacceptable toxicity. Primary endpoints were PFS, and secondary endpoints were OS, overall response rate, and safety. Again, well-balanced baseline characteristics. So we have the PFS curves almost overlapping, but there is some numeric difference. The median PFS was 33.1 months against 26.2 months with a hazard ratio of 0.89, but this was not what was pre-specified to be significant. And the other points, efficacy endpoints like overall response rate, CBR, DOR, they were almost similar between the groups. OS was also not reached in both the groups, so no difference. If we look at the overall toxicity profile, so most of the toxicity was as expected with these agents, but a specific toxicity of giredestrant was that of bradycardia, but the maximum grade of bradycardia was not more than 2. So the key takeaways are that it improved PFS numerically, but failed to do so as per the statistical significance endpoints. It was well tolerated, had manageable toxicity, and we need to have further exploration that which will be the specific subset of patients who might benefit from this combination, as we know that it has proven efficacy in the first-line setting. It has proven efficacy in the later lines of setting, but why does it not? So we need to have further exploration, and there are a few trials which are coming in. The next will be that I will be discussing is reduced trial, in which they looked at the reduced dose density of denosumab in the prevention of symptomatic skeletal mets. The key takeaways were that Q12 weekly is non-inferior to Q4 weekly. Toxicity profile is much better. And of course, we all understand that the cost benefit is always there. So in this trial, they took 1380 patients, randomized them to receive the standard denosumab every 4 weeks versus arm B, in which they had every 12 weekly denosumab after an initial induction. The primary endpoint was time to first symptomatic skeletal event, and secondary endpoints were toxicity and overall survival. So the patients taken into the study had either metastatic prostate or breast cancer, and it is very important to note that majority, like 60% of the patients, had more than 10 skeletal mets, which means that a pure significant osseous metastasis was there. And so now let's look at the cumulative dose and doses. So we can see that as per the schedule, of course, the patients will have lesser doses and lesser dose frequency in the experimental arm. So this is the time to first skeletal related events. So we can see that the curves are overlapping. There is no difference even amongst the specific skeletal related events. Secondary endpoint of time to second or subsequent skeletal related events was also not different. However, the time to first occurrence of hypocalcemia, there is clear separation of curves, and the hazard ratio is 0.7 in favor of the reduced dose density. Again, similar trend goes on for ONJ and tooth infection. So the key takeaways from this trial are that Q12 weekly is better, is non-inferior, it's better in terms of toxicity and value. Thank you very much.
So I'll request everyone to please scan the QR code. Okay? Please scan the QR codes, put your code, and fill the feedback form. And I would like to call our panelists on stage. Dr. Kausar Bano, she is medical oncologist at Jinnah Hospital, Lahore. And next is Dr. Mohammad Ijaz Khan. She is HOD Cancer Ward, Atomic Energy Cancer Hospital, Pinham, Faisalabad, and Maria Kuptia from the Shaukat Khanum Hospital. And Dr. Sulma Sahib Jam and Dr. Etain Brand would also be joining us online.
Thank you, Brian, and thank you, Solmaz, for joining our slightly late panel discussion, and I'm really grateful that both of you sat down and waited for us. I can't see their faces because we would like to could you please put them on? Hi. Hi, Brian. Hi, Solmaz. Thank you for coming, and thank you for joining despite your busy schedules. It is somewhat late for both of you and early for Solmaz. We have a few questions which we would like to ask. Solmaz, with the sacituzumab data, will HER2 low and ultra low make a difference for the ADCs or not?
So the question is, sorry, what was the exact question?
We are now dividing the HER2 into low and HER2 ultra low. Will it make a difference? Does it matter, or does it not matter and it's unimportant?
That's a good question, because we don't have really head-to-head study of all these basically ADCs with different topoisomerase inhibitor payloads. So we really don't have the efficacy data of, say, to know if deruxtecan as a payload is better than other payloads. I think that what will be my choice if it comes up will be also like thinking about the toxicity profile here, and the access So I don't think that there will be a difference. It will be like more like a choice that we have. And then I think that's exactly the same here, like in my talk, you know, like I covered 3 studies, and one of them also was dapirolizumab deruxtecan. So, and it was like, okay, are we going to use sacituzumab govitecan, or are we using dapirolizumab deruxtecan for these patients? Because these are the similar patient population, maybe a little bit, the study was done a little bit differently, but similar patient population. And I think that, again, it comes down to toxicity profile, you know, looking at each patient and seeing that, you know, which drug makes more sense, and also access.
The second question which was asked by the audience was that the ASCENT 3 and 4 trials do not show an overall survival benefit, but the progression-free survival is there. Should we routinely offer that as a first-line treatment in view of the fact, especially in our part of the world, if the overall survival benefit has not come out yet? The data was for PFS, not for OS.
That's a very good question. And I know that there's also some surveys ongoing, so that should we really consider these data? I would wait for OS data. I would wait for OS data because, again, it comes down to, you know, is it going to change the overall survival benefit? Is it going to change the overall survival? And also the financial toxicity of it. I would rather wait, even like, you know, where these drugs are available, I like to have, it's not just because of PFS data. I think that we shouldn't just jump and do it. I think we should be more critical when we look at these data and really go case by case. And I would wait for OS.
The third question by consultants was that in BRCA mutant cancers, should olaparib be added concurrently, or first we should use our drugs and then add sequentially, or what should we do with olaparib if they are BRCA mutant cancers?
Is this question for me?
Yes. You were talking about the BRCA mutant cancers, right?
All right, okay, yes.
When should olaparib be added? Sequentially or concurrently?
Yeah, so these trials didn't really look at the combination. So I think that that's something to consider in terms of, you know, the toxicity profile. And also we won't have the data on the efficacy of it. Especially when it comes to toxicity, the bone marrow suppression, you know, sacituzumab govitecan is, yes, in this study they showed that there was a lower rate of, you know, discontinuation because of toxicity, but we know that these drugs are also toxic. So I don't think that I would not add it to sacituzumab govitecan without data showing, you know, that's safe. I think that, you know, to use, I think that would be more like in favor of using PARP inhibitors in a setting that's already approved first, and then using sacituzumab govitecan later.
Okay. There's a question for Brian. We quite often see patients, older patients who are frail, multiple comorbid, and we first send them for surgery. But their Ki-67 is like high, and these patients have advanced tumors. Should we go for them for getting chemotherapy like a single agent, CMF? And if they are ER negative, or do we do nothing and wait for the disease to come back? You've already shown very elegantly that the survival is not due to the mortality is not due to breast cancer, but more due to other comorbidities. So this is a question which we ask because there are a lot of older women who are coming with advanced disease, not telling their families, and they just walk in, and they have a high Ki-67. What should we do with these cases? With large tumors, we've done surgery, which is the least toxic of the things, and then how do we proceed further? Now, the NGS sequencing is not done routinely, or the Oncotype DX for these patients is not done routinely because it's expensive and sent out of the country. And for the middle income group, the low income group, and even for the high income group, sometimes they don't want all this done. So how should we approach with a high Ki-67?
I think the high Ki-67 is brings the meaning of high proliferation, and that there is a role for chemotherapy. But of course, when you have a patient with some level of frailty identified clearly clinically, I think you should take a priority on this in order not to trigger any catastrophe with decompensation or high level of adverse events. So the rule of thumb, which is poorly demonstrated but is in limiting the number of drugs, so monotherapy should be probably a goal, and if you look for a cytotoxic agent, and to use something which should be adjusted in terms of dose, in terms of schedule, and not copying or pasting what you do in younger ones. I mean, very often we have large adjustment in terms of dose reduction or dose intensity. So I think that's really important to stress this, and I'm very surprised, and I even challenge you to find appropriate and representative sample size of all the patients in these studies that have been discussed regarding the escalation, which shows you that we are not completely correct in how we develop things.
The other question, if they are ER positive, you again showed that the CDK4/6 inhibitors were better than the chemotherapy in this group of patients. Now, if we use CDK4/6 as adjuvant with high-risk patients, should we use Palbo, which has not shown a survival improvement in these patients, or Ribo and abemaciclib are going to be more toxic? And Palbo is generally better tolerated than these drugs.
I think given, again, that in this population, we need to pay attention a lot on the benefit-risk ratio. The profile of tolerance of palbociclib makes it a much easier treatment to handle in older ones. And that means that it's probably because of this that if you pool the data from Ribo, abemaciclib, and Palbo, like in this Italian large real-world series, there is no difference, no clear difference between these three compounds in terms of efficacy, because you have many more adjustments with abemaciclib and Ribo compared with Palbo. And that's why Palbo is certainly, from my point of view clinically, the easiest drug to combine with endocrine treatment in older ones, certainly. And that's why there is a trend also in these real-life data for this use.
And I'd like to ask our local panelists, what do you commonly use when you need to use a CDK4/6 inhibitor in breast cancer? Which is the most common and why do you use it? Kosa, Maria, Ijaz, what is it? Our local panelists are three people sitting here who are head of departments in various centers, and we would like to ask them what is their take on this.
In elderly population, definitely we, based on the patient's comorbs, we very wisely select the CDK4/6. As we have seen that with the ribociclib, we have to do a strict monitoring. With the Abema, I'm using it, and patients quite often they do have deranged RFTs. So most of the time, my first choice is palbociclib for my aged patients.
Okay. Maria, do you use it in adjuvant therapy for the elderly if they are high-risk patients for recurrence? Or do you skip it and say, okay, the comorbidities are much higher, I don't want to use it, and I'll just go on hormonal therapy? Because if you look at the survival difference, it's only 2 or 3%, right? Yeah. For 5 years.
So you are talking about metastatic disease, right?
No, adjuvant.
Adjuvant.
So unki tasveerein rehne de yahan.
So in adjuvant setting, like At the moment, I'm just using ribociclib because that is available. But I select my patients very carefully. If they have got comorbids, and usually for elderly, their tumors are not that aggressive.
No, but when you have an aggressive tumor, you need to do something. Would you like to use a CDK4/6 inhibitor, or would you just leave them on hormonal therapy?
So I guess for elderly, I would just leave them for later if they progress.
If they progress, because
Yeah.
the mortality is, as Brian showed, and this is much higher with this thing. Ijaz, what is your opinion on CDK?
Madam, we would, Madam, risk stratify the patients. If a patient gets a huge lymph node status, for example, she gets 10 lymph nodes or more than 10 lymph nodes, then we do definitely use the CDK4/6 inhibitor.
Even for older patients?
Madam, if the patient is 65, 60 plus, then we may omit. But if she is younger than 60, then
No,
I
if the
think
patient
we
has
use it.
more comorbs, then yes, in elderly, we should skip CDK4/6. But in relatively the population that is around 60s and with good performance status, yes, we need to choose.
Okay. Brian, do we need to do a frailty index in all patients over 65, or should we just quickly eyeball them according to performance status, comorbidities, and polypharmacy, and say, okay, this patient qualifies for chemo or no chemo or hormonal therapy alone? And how do we look at the life expectancy? Is there a life expectancy table where you fill in all these things and say the chances of this patient dying, and even like falls and all this, we have to look into all this. So what is your opinion?
I think from the age of 70, there is a high recommendation to have a specific look at the health status in a different way that we do in younger ones. I mean, it's really first to force the oncologist to look differently at the patient without overlooking on other issues. And just a screening tool, a very light tool like the G8, which is 8 questions in 3 minutes, can open many doors to adjustments. And that's so important because it brings you back to reality of what you're doing and not to focus blindly on results obtained in highly selected population and in trials unfairly run in younger ones only. So that's a very important step in the shared decision making and in the process of decision, you see.
So you look at the geriatric patients from a different angle and say, okay, let's look at these 8 questions and grade them. So if it falls like 40, 50 and 50, then what do? You discuss it.
Sorry?
You said you look at the 8 things which you identified and then decide what the frailty index is.
I mean, it brings you to revise the treatment intensity that you intend to deliver to your patients. And I mean, to have a notion, to take a decision regarding someone above an age of 70, 75, it is important to get this feedbacks, this clinical feedback, and this notion of life expectancy. You have tables online on eprognosis.org, which provides you with a 4, 5, or 1 year life expectancy estimates. And that's so easy to do it that you can really balance that or confront that to the goal of the treatment that you want to apply. If you want to get something at 10 years, if there is a high risk of death before the 5th year, it can question a lot the intensity of what you want to deliver. So that's important. This step for me has become almost mandatory. It's never to block a treatment. It's more to acknowledge that we have to adjust very often and not to waste what we have in hand in terms of expensive drug, expensive treatment, inefficient ones.
There's one question from the panelists.
I have a question for Dr. Solmes. In the patient who are triple negative and they have low or ultra low HER2 positivity, What is, if patient gets toxicity on one ADC, depending, considering that the different ADCs have different payloads and their structures are different, can we use an other ADC in the sequence? What is your line of sequencing regarding the ADCs? And if a patient gets toxicity on one or progresses on one therapy, can we switch patient to the different agent?
That's a very good question, and this is something that our field really needs to look at. And there are actually studies looking at sequencing these ADCs. Again, here we are talking about the different payloads, but mechanistically they're all topoisomerase inhibitors. So, and so far the studies have shown that when a patient after a progression of the disease, when you go to the second ADC, which has the similar mechanism of action, then the duration of response, first of all, the rate of response is lower, and also if you get a response, the duration of response is lower, so the PFS is lower. So going from one topoisomerase inhibitor to another one here, of course, we shouldn't expect a significant response. But to your point, these are different drugs and also the targets are different. In a case that, if someone has a disease progression, then I will be very careful in terms of selection of, of the next chemotherapy agent or next therapeutic agent. Again, looking like what we talked about frailty, the importance of looking at the patient as a whole rather than looking, okay, this is the drug that I have, should I give it or not? I think that this needs to be very individualized decision. But then in terms of drugs, I wouldn't go right away from one ADC to another. I wouldn't go from, say, sacituzumab, govitecan to trastuzumab deruxtecan, or the other way around, because of the mechanism of action. I will look at other chemotherapy agents with different mechanism if they can be used as a next agent in a patient who is in a good condition to receive the systemic therapy. When it comes to a patient who couldn't tolerate one, then that's a different story. Then it makes sense if someone didn't have a disease progression and say had pneumonitis on trastuzumab deruxtecan. So yes, then it makes sense, and there was no known resistance to the drug. So that makes sense to think about, sacituzumab govitecan, or the other way around. I don't have any preference on one over another. Again, because of lack of data. I hope this answered your question.
In patients who have brain metastatic disease, HER2 positive patient, we just have the data of HER2 climb. And we have excellent results as per the DESTINY trial with the TDXT. So in your opinion, on what basis a clinician should select among the two regimes in patients with HER2 positive metastatic breast cancer patients in the frontline setting?
Yeah, that's a very good question. So my experience has been that we are getting longer intracranial response with trastuzumab deruxtecan. So I have patients who have with brain metastasis, with HER2 positive brain metastasis, that now I have them on trastuzumab deruxtecan for more than 3 years, 4 years or so. So the duration of response, intracranial response, is longer, both in clinical trials. If you look at HER2 climb, that was about 7 months to 9 months, and in trastuzumab deruxtecan on DESTINY trials, that's longer, so it's more than 12 months. So my experience, if you look at duration of response, in clinic also I see that the longer intracranial response from trastuzumab deruxtecan. But then it comes down to toxicity. Trastuzumab deruxtecan is more toxic, even in patients who are young and fit. I've had a patient who's a marathon runner and in her early 30s, and for such a patient, it's very difficult to tolerate trastuzumab deruxtecan that she has been getting it because of both intracranial and extracranial metastasis from HER2 positive breast cancer. In the other way, in the other side, the HER2 climb, I feel like is better tolerated than trastuzumab deruxtecan. There's like more like ways of dose reducing or playing with the dose of, capecitabine and tucatinib. So again, goes back to patient itself and like how the patient is looking and was the friendly. In elderly patients, I feel like they're tolerating maybe like HER2 climb regimen better. But say if I have a fit patient, nowadays my choice and colleagues who do brain metastasis, a lot of us, we go to trastuzumab deruxtecan first.
I think we now have to proceed further to the next session. I would like to thank both of you and for your patience and guidance and your help. A very interesting discussion. We were late slightly by about 15 minutes. I'm so sorry about that. Thank you very much. I really appreciate it. Bye.
Assalamu alaikum. Good evening, ladies and gentlemen. This is Dr. Tahir Bashir. After this wonderful session on breast oncology, let's talk a little bit more about breast cancer. Let's talk about early breast cancer, and let's talk about Kisqali. The slogan for this session is Kisqali Rises, Turning Fear into Confidence. I'm thankful to Nuvo Pharmaceuticals for coming up with this wonderful session. We have an excellent speaker who has command on breast oncology and 3 experts from various institutions across Pakistan. Let me introduce the keynote speaker for today, Dr. Shahina Dawood.
who is going to get this award. Anybody who does not know about Dr. Tariq Siddiqui, he is a medical oncologist basically from Karachi. He did his schooling from St. Patrick's High School, attended DJ College Karachi, and graduated from Dow Medical College Karachi in 1967. He did his house job from Civil Hospital Karachi and did his internship from New York, Mercy Hospital, Buffalo, New York. He did his residency in internal medicine from Wayne State University, Group of Hospitals, Detroit, Michigan, and then fellowship in hematology, oncology, and bone marrow transplant from Henry Ford Hospital, Detroit, Michigan. He is a certified American Board of Internal Medicine, Hematology, and Oncology, and fellow of the Royal College of Physicians in Canada. Dr. Siddiqui did his initial practice in Florida, USA. And then he came back to Pakistan in 1995 and joined Aga Khan University Hospital as a consultant hematologist oncologist and the Badruddin Hassan Ali Ajani Professor of Medicine. He was also acting chairman Department of Medicine from 1995 to 2002 and chief of oncology and head of clinical trials at Aga Khan Hospital. Then he left back to US and did worked as a hematology oncology professor and consultant at Florida, Gainesville, Florida. Okay. In 2013, he came back to Pakistan and joined Zawdeen Memorial University, North and South Campus, as a professor and head of the department. He worked there from 2013 to 2021. Dr. Siddiqui has vast experience of research and author and co-author of more than 65 publications. He is a member of American Society of Clinical Oncology, European Society of Medical Oncology, fellow of the Royal College of Physicians, Canada, and Pakistan Society of Medical Oncology. He was, while he was in Pakistan, he was involved in the Sindh Governors Committee for Cancer Control Management in Sindh. He was a member of Faculty of Oncology, Pakistan's College of Physicians and Surgeons. He is the founding member of the Association of Pakistani Physicians of North America, also known as APNA, and the founding member of Pakistan Society of Medical Oncology. He is also a founder of South Asian Regional Cancer Association, SMRC Oncology. Currently, he is working as a consultant hematologist oncologist at Walker Cancer Center, Watertown, Roosevelt Park Cancer System, New York, since 2021. Okay, while he was in Pakistan, Dr. Siddiqui was very instrumental in the field of oncology. He has been always ready to help early career oncologists in mentoring them in recognition for his contribution, commitments, and services in the field of medical oncology in Pakistan and abroad. And the Society of Medical Oncology Pakistan is honored to confer the Lifetime Achievement Award to Dr. Tariq Siddiqui. May I request Professor Zebaziz to please come. And Dr. Adnan Jabbar.
Dr. Buttar, Jamshed, are you guys in the hall? Thank you everybody for bearing with us. It was a long day. I know it's 9 o'clock. You guys must be hungry. So please, for all the residents, and I don't see a lot of residents here, 8 o'clock, who has already registered for the Oncogene program, Onco Edge. Our sessions will begin sharply at 9 o'clock. We like to keep on time. Today we had to push ourselves in order to keep us on time. We have international speakers who usually wait for us online. That's why we want to be on time, and that has been our signature. We will have a lucky draw before each session. It's going to be tablets, it's going to be cell phones, so if you are the lucky one. If we have only 10 people, those 10 names are going into it. And if your name is out from here, it will not be put in again. So you do not win if your name has been called and you're not in the room. Once again, thank you very much. Dinner has been served. Enjoy the rest of the remaining whatever evening is there. See you guys tomorrow.